Good morning, good morning, good morning. Can you all hear me? Not wanting to start late, I just thought I should introduce myself. I'm Dr. Gail Weeks, physiotherapist, Vice President of the Barbados Physiotherapy Association. So we're not officially ready to start yet because there's so much enthusiasm coming through the door. We want to give everybody a chance to come up, come in, meet, greet, settle themselves, and then get going. So just give us a few more minutes, okay? And then we're ready for everybody. But I'm so glad to see everyone here. So again, welcome. Just a few minutes. Thank you.
my baby, my Valentine. Can I you the making my temperature rise? If you leave me a good time, I swear. You are like the oxygen I need to survive. I'll be honest. Loving the thought of me, I am so obsessed. I want to chop your own. Never did it back at this feel. Open up, make us feel. Yeah, my love, one thing. We make a bad man sing.
I go spend for your head. Talk all they want, I don't care what they say, cause your matter. Now him I con the carry for my head every night. Now you I want to carry to my bed, oh no no. Don't tell me no no no. You can be my partner, never riding solo no. And we got no one lucky, no need to party wo. I feel it what you're doing, oh yeah baby, gotta go. No. Your body they back at me, see. Open up, make I see. Now you where they got my fancy. They do me Yankee Panty, oh no 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 no.
And they call me. Girl, I want to go, but you got me coming. Why should I be coming early in the morning? Oh yeah, shake it, make it spend my money. Call me Mr. Bean, I go make you honey. Hey, give me, baby, make you give me. I go show you love and I go take you to my city. Don't need let them make I look pity. You won't make us sing me before you go see me. Fine girl, you know your body bad. Same body back can make you shake it for Ghana. Here dancing for me, baby pan. Come and give me show. Rockstar. Body they throw me like a bono. Body they rise in my no. I say color your crocodile, no good this locodo. Kelly they bossy my pololo. Can make a salute your commando. Tell if you balance Diego, I give you paper. No go do me Diego, my Maradona. Tell if I lap your sueto, I'm a farisa. Tell your back, keep it connected, and I can follow your cresco. Sunday, down the cresco. Pay for your waist, and I could pay for your lace, a day for your waist. Sunday, down the cresco. Pay for your waist, I could pay for your lace, Diego, I give you paper. No go do me Diego, my Maradona. Tell if I lap your sueto, I'm a farisa. Tell your back, keep it connected, and I can follow your cresco.
Holy fire, holy water, holy money, only money, only money, only money. We are woody fire, woody thunder, only money, only money, only money. Let the mare bless you with body, oh baby. Oh. Star boy go bless you with money, oh my girl. Let the mare bless you with body, oh baby. Oh, star boy go bless you with money, oh my girl. Yeah, man, sucker, 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 baby. Sucker, 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 sucker. Oh, yeah, give him lock up. Lock, yo, yeah, give him, baby. Sucker, sucker, sucker.
Oh, when I come through, they know we survive, so they turn up all eyes on me now. So many things we fit to do with your magic, baby. Stop getting plenty money.
You can all be seated. Good morning. Good morning. For those I didn't say good morning to before, good morning again. Okay, I am your MC for today, Dr. Gail Weeks, physiotherapist, presently the Vice President of the Barbados Physical Therapy Association. So again, welcome. And on behalf of the Barbados Physical Therapy Association, I want to welcome my esteemed colleagues, professionals, patients, caregivers, advocates for stroke. I see within in the audience our head of the rehab department, Dr. Mosley. Welcome. So overall, welcome to our stroke symposium. Today we gather to exchange knowledge and share advancements as it relates to stroke. We see that this, as a collective mission, aims to advance stroke care in Barbados, aims to look at prevention of stroke care in Barbados, and also improving the outcomes for patients with stroke in Barbados. I emphasize Barbados because this is about Barbados today. So our focus this morning for the next 3 hours is to provide all of you in attendance here and online, yes, we're online, with a holistic approach to stroke prevention and management. I hope that at the end of this symposium, we leave more informed than when we came through these doors this morning. I would now ask for Dr. Nicole Grant, physiotherapist, to come and lead us in prayer before we start our session.
Hi, good morning. Let us all stand. Those who can stand, let us stand. Let's bow our heads. Father God, we give you thanks, Lord. God, we give you praise. We thank you, Lord, for bringing us, Lord, together, Lord, for such a time as this, Lord, for this symposium. Father, we speak, Lord, a blessing upon each speaker. God, that you'll give them the wisdom, God, and the knowledge, Lord, to speak, Lord, that, Lord, those in the hearers, God, would understand. God, I pray, Lord, even for each patient, each person who've had a stroke, who have a family with stroke, God, we pray, Lord, that you will strengthen them. God, you'll give them the patience, God, to work, Lord, with them, Lord God, and we pray, Lord, for your healing, Lord, upon each family, Lord God. Father, we pray for those who are coming, Lord, we pray, Lord, you'll bring them, Lord, safely, and Lord, may we learn, Lord, everything you want us to learn here today. But God, we pray for your peace. We pray, Lord, for your joy. We pray for wisdom to prevail. And Lord, in all things, Lord, we give you thanks. In Jesus' name, amen. Amen. May be seated.
Thank you, Dr. Grant. Okay, so we're going to invite Dr. Mandeville to this platform. Dr. Mandeville is currently the acting senior medical officer of in the Ministry of Health, responsible for NCDs. She has worked closely with many projects pertaining to improving NCD management in Barbados, and is presently conducting research with the University of West Indies on NCDs and behavioral changes strategies to empower persons to self-manage their condition. So right now, before we officially start our journey in stroke management, I invite Dr. Mandeville to the stage.
Good morning. I want to say a pleasant good morning to all my esteemed colleagues, to the patients, and to the caretakers who are here today and those who are listening online. It is definitely my privilege to give the opening remarks today at this 2024 Stroke Symposium, entitled A Holistic Approach to Managing Strokes, hosted by the Barbados Physical Therapy Association, who have been passionate in promoting high standards of physical therapy practice and education in Barbados, as stated in their mission statement. And this association has also voiced their vested interest in the fight against non-communicable diseases and its effects. Non-communicable diseases affect us all, either through our work as health professionals when we care for those patients, or when we lose someone we love to a non-communicable disease. In addition, many of us in this room know someone with a non-communicable disease, or we ourselves suffer from a non-communicable disease. Chronic non-communicable diseases, or NCDs, are the leading cause of morbidity and mortality worldwide, and in many developing states such as Barbados. A large proportion of this mortality is attributable to cardiovascular disease, including strokes. The latest edition of the World Health Statistics alarmingly shows high levels of many of the key risk factors for NCDs. Every year, an estimated 17 million people die prematurely from non-communicable diseases, which equates to 1 person every 2 seconds on average. Can you imagine that? Roughly 86% of those deaths are in low and middle income countries such as Barbados. NCDs are therefore a significant threat to global health, equity, and development. They destroy lives, livelihoods, families, communities, and economies. In Barbados, approximately 13.6% of deaths are due to strokes or cerebrovascular accidents, which translates to approximately 384 persons per year. This statistic is quite significant and has ranked Barbados as being the 119th country in the world in regards to the number of deaths caused by strokes. The University of the West Indies, in collaboration with the Ministry of Health and Wellness, has implemented a population-based multi-non-communicable disease registry, collecting data on all cases of strokes, heart attack, and cancer island-wide. For survivors of stroke, neurological deficits can persist, resulting in profound morbidity and dependence, as well as considerable healthcare costs and loss of productivity, which can impact at both the individual and national levels. Prompt and efficacious management of acute stroke is an important determinant of patient health outcomes, and the efficient allocation of medical resources, in addition to the provision of post-stroke care through physiotherapy, is critical to ameliorating the impact of strokes on our society. In the Sustainable Development Goals, countries have set a target to reduce premature deaths from non-communicable diseases by 1/3 by 2030. So I am delighted and honored that such patient care approaches, as outlined in this symposium, will be presented to showcase a holistic strategy in order to empower patients, their relatives, caregivers, and the community for NCD prevention and control, which will champion action on NCDs nationally and globally. The commitment that we have as healthcare professionals is to protect people living with the non-communicable diseases and, by extension, strokes. We need to support access to quality, essential health services, to strengthen surveillance and monitoring systems, and to engage people living with NCDs to optimize their health and lifestyle behavior. NCD management, for the most part, is both affordable and achievable, with economic and social repercussions far beyond health. And to build on this momentum, we must act now. Our region faces a looming threat posed by the NCDs and climate change, and small island developing states such as Barbados remain overwhelmingly vulnerable to these threats and can take action to protect the health of their people. First, non-communicable diseases must be mainstreamed within the primary and tertiary healthcare sector. This means increasing access to screening, diagnosis, and treatment for the NCDs. It also means reorienting our health systems towards community-based care, which means reducing the geographic, financial, and cultural barriers to ensure more people can appropriately manage their chronic conditions. Secondly, we require multi-sectoral collaboration to address the underlying socio-economic factors driving the non-communicable diseases. Nowhere is this clearer than in the small island developing states, where especially we are vulnerable to the economic and commercial determinants of health. We must therefore engage with professional associations, such as the Barbados Physical Therapy Association, to enact policies to help prevent the non-communicable diseases. What has been achieved so far in relation to NCDs and stroke management is a hopeful sign of progress. But our current efforts are not enough to reach the Sustainable Development Goal of a 1/3 reduction in NCD premature mortality by 2030. This is an ambitious goal, and this is why this symposium is an invitation for us to embrace this agenda with all our might and go above and beyond what we've done up until now to assist those living with the non-communicable diseases, especially strokes. We count on your commitment, investment, and action, just as we count on each other to address the non-communicable diseases. Thank you.
Thank you, Dr. Mandeville. I think she really started the ball rolling there. So quick question, how many persons in the audience does not know anyone else who's had a stroke? Not one person, okay? So therefore, what we as the association want to do is to make sure that when you come through your door, we are going to do a journey from the beginning to the end of knowing stroke, managing stroke by the end of the day. All right, so the first person's going to come up to our platform is Dr. Christian Curtin. Dr. Curtin graduated from medical school at the University of West Indies, Cave Hill campus in 2015. After completing her internship in 2016, she obtained a postgraduate diploma in diabetes with a distinction from the University of South Wales in 2018, and a master's degree in clinical exercise physiology from Springfield College, Massachusetts in 2021. She is currently a resident in internal medicine at the Queen Elizabeth Hospital, where she has been for the past 3 years. She particularly enjoys neurology and learning about rehabilitative medicine. Dr. Curtin is an ACLS instructor with the Heart and Stroke Foundation. And for fun, Dr. Curtin is also, I don't know if it's fun, a certified personal trainer and a corrective exercise specialist. So I'd like to welcome Dr. Curtin to the platform.
Hi, good morning, everyone, and thank you for coming to today's symposium. All right. So I've had the distinct pleasure this morning of kicking things off from a medical perspective or from a doctor's perspective. And today's presentation is entitled Stroke Risk Reduction. What you can do, so what the patient can do to reduce their risk of having a stroke. Our objectives this morning, because we all need to be able to achieve something by the end of this. We're here to learn, and we're here to learn together. So we're going to look very briefly at the types of stroke. We're going to look at how common stroke is in Barbados. Then we're going to look at the factors that influence your risk of having a stroke. And what's the fun in looking at those factors if we don't look at what we can do about it? So we're going to look at the things that we can do to reduce our risk of having a stroke. So let's define it. What is a stroke? I don't like to assume, what happens when we assume. So we need to start off with a definition. So a stroke is a neurological event, neurological meaning something that happens in the brain, something that happens to our nerves, it affects our muscles in the end, and it occurs very suddenly when there's a blockage to blood flow in the brain. It can also occur if there's sudden bleeding in the brain. And the type of symptoms that we see all depend on where in the brain is affected. So for example, if a stroke has affected you on the right side of your brain, that's why you see symptoms on the left side. If the stroke occurs on the left side of the brain, that's why you see symptoms on the right side. If the stroke affects your speech center, that's where you get difficulty speaking. So it all depends on where in the brain the blood clot is or the brain bleed is. Now, what exactly is this? Now, we all know a little bit about plumbing. I just know a very, very little bit. But let's talk about pipes right now. So if we can all envisage pipes and plumbing, we can say that our blood vessels function as this, all right? So in order for blood to flow through the body, these pipes or blood vessels need to stay clear. If there is a clot, for example, if your plumbing system gets blocked, we call that an ischemic stroke, or I like to refer to it as a brain attack. So the same way how we think about heart attack, we can also have a similar thing happening in the brain. So that's a brain attack. There's a clot in the brain. Now, we all know in Barbados that we've all passed these burst mains on the road. And similarly, our pipes can burst. Our blood vessels can burst. And that's called a brain bleed. And that's the second type of stroke that occurs, not as common, but as equally serious. So these are the two types. And why does this matter? This matters because we can't tell by looking, at least not with our eyes. So if there's one thing you take from this presentation, and I hope you take more than one, but if there's one thing that you take from this presentation, it's that not everybody with a stroke gets aspirin, right? And this is why. So if you're home and you see somebody, you think they have a stroke because they have weakness on the right side, this could be caused by a clot, or this could be caused by a bleed. The clot is treated with aspirin. The bleed is treated with not aspirin. So we could make it worse if we give aspirin at home before they get to the hospital. So that's point number one. So when you get to the hospital, you get something called a CT scan, which we're seeing here. The middle one is the normal, all right? Just see something gray and black, that's normal. Just believe me on that one. And the one on the left, the white shiny stuff there, that's blood. That shouldn't be there. So this person doesn't get aspirin. And the one on the right, the far right, you can see that area that is dark, almost black. That is dead brain or dead brain tissue, and that's caused by a brain attack. Now you can see it's on the same side, so that person is going to present with weakness on the right side, but guess what? The one on the left gets aspirin, the one on the right does not. Excellent. You learned something today already. great. So why does this matter? You know, when I was in medical school all those years ago, as you heard just now, there was a concept that if you don't think that something will affect you, you're not going to pay attention. All right, so I wanted to just mention very briefly about the numbers. So what's your risk of having a stroke if you're living in Barbados? Now, this is from 2021, and I recently saw some statistics from 2022 from the Barbados National Registry. And what they found is that almost 700 cases of stroke were recorded in 2021. 700. Majority of those were caused by brain attacks, so clots in the brain, which is similar to the rest of the world. And only about 10% were caused by bleeds. Now, what is important is that it's no longer just a disease of the old. So when you were growing up, you would hear grandmother, great-grandmother, great-grandfather, they had a stroke. And we would say, okay, it happened with age. But now I think I could refer to my colleagues and say, you know what, we're seeing 50-year-olds, we're seeing 52-year-olds. I don't know about you, but that's still young, all right? We're seeing 59-year-olds. This is still young. These people are still working, right? And as the retirement age gets pushed, that's a conversation for another day, we're losing productivity, right? So all of those are precious years that we could be working that we know can't work. So this is why this symposium is so important, because we need to reduce our chances of having a stroke. If we like stats, well, they figured this out. Well, if you like stats in the US, the numbers actually estimate that every 40 seconds, and we could count to 40 if we wanted to, but I won't challenge anybody right now. But every 40 seconds, somebody in the States has a stroke. Every 40 seconds. So does it matter? I think it does. And if it matters, then we need to be looking at what we can do about it. And that brings us to the risk factors. So with risk factors, there are two types. I can't get away from medical speak with this slide. There are two types of risk factors. Modifiable, those are the things that we can do something about. Non-modifiable, those are the things that we can't really do anything about. So let's start with the ones that we can't do anything about and then move towards some positivity. So we can't do anything about age. They say that the older you get, the more likely you are to have a stroke. I don't know about you, but I look forward to my old age, so we don't want to do anything about that. Ethnicity, Black persons are more at risk to having a stroke than white persons or Caucasian persons. Again, I'm quite fine with being Black, so we don't need to do anything about that. Gender, women are at higher risk than men, although with our numbers nationally, we see that they're almost equal, right? We almost have an equal incidence of men and women having strokes. Family history, you can't go back in time and tell your grandmother not to have a stroke, so you can't do anything about that. If you've had a heart attack, if you had a stroke before, again, you can't go back in time. So those are the factors that increase your chances, but you can't do anything about it. But we're here today to find out what we can do something about, and that is the modifiable risk factors. The two culprits, so again, lesson number 2, so you're listening up at this point. Lesson number 2, the two culprits that increase your risk of having a stroke that you can do something about are hypertension or high blood pressure and diabetes. So can you go back in time and tell the doctor, no, I don't have hypertension? Some patients have tried, right? But what you can do is you can affect your future and have good blood pressures. So even though you have hypertension, you can actually still have excellent blood pressure control and reduce your risk of having a stroke. So the stuff that you can do something about, high blood pressure, diabetes, cholesterol, those travel in a pack together usually. Obesity, so we can do something about our weight. Smoking, nothing good comes from that. And alcohol in moderation or just cut it out, all right? So I have a friend here who I brought with me who is eager to share his story. And I want us to hear about his medical history. So in case you didn't hear, I asked him about the medical conditions that he had before, and he said that he had high blood pressure and he was taking medications. Emphasis, and what intrigued me there was this past tense, and he was taking medications. But we're gonna go into that a little bit later. So tell me, did you have any medical conditions before you had the stroke that you knew about?
Yeah, I had high blood pressure. I was taking medication.
But I wanted to know some more. So let's ask him some more questions. No diabetes, no cholesterol.
No cholesterol.
Okay. Did you used to smoke?
And drink.
So, that is what I did as well. Silently, yes? So I liked his honesty, all right? Next slide. So I liked his honesty. So when we sat and we continued the conversation, I realized what his risk factors were. So, no diabetes. Right. So when we look at the non-modifiable, so the stuff that he couldn't do anything about, you can see how he looks. I won't tell you his age, but he's over 55. He couldn't do anything about that. He's black. He couldn't do anything about that. And he didn't have a family history, and he never had any issues before. What he did have was high blood pressure, and he stopped taking his medications. What he did do was smoke. He wouldn't tell me how much. And what he did do was drink. So these were the three things that maybe, just maybe, if he had known before and addressed it, he could have prevented it. Just maybe. I'm not God, we're not God, but just maybe. But that's the point of this symposium, finding out what we can do to change our course. So that brings us to the action of today. So what we're going to take away from today are the A, B, C, D, and E's. These are the things that we can do to reduce our risk of having a stroke. A1C for A, blood pressure. B, cholesterol. C, D gets two things, diet and drugs. E, my favorite, exercise. And S, to really stop smoking. So I was going to offer a prize at the end, but then I said, you know what? Knowledge will be your prize. You don't need a prize. Next slide. So A1C. So A1C, I want you to remember this. If you're writing this down, this is the time where you stop and write. This is the time where you snap a pic of the screen. I don't mind at all. I don't know if you can do it. Yeah? Snap a pic of the screen, because this is what I want you to take with you. So A1C is a reflection of your blood sugar control. So the next time you go to your doctor, if you have diabetes, you take out your pen and your paper, you take out your phone, the notes section, ask your doctor, what is my A1C? Because that tells us how good your blood sugar is and how good it has been over the last 3 months. Tells you if it's controlled and if you're doing what you can to reduce your risk. Anybody remembers what B is? Excellent, excellent. I can sit down now, right? That's what you're saying. So B is blood pressure. And this picture here is worth 1,000 words, because guess what? She's sitting in an upright chair. The arm is out at heart level. She has her paper and her pen because she's recording. Remember, if you're sharing your blood pressure machine with somebody at home, it's integral that you do what? You write down your blood pressures. I don't want you to get to the office and say, no, that high one isn't mine. You know, we won't believe you. All right, so write down your blood pressures. Cholesterol, these are the things that stick in the pipes and cause blockage, so we want to control that as well. And we're going to do that, Dwayne, we're going to do that with diet and drugs, all right? Drugs, these are the good kinds. These are the ones that comes from the doctor. Now, I'm not going to talk about the other facilities, but I want to let you know to please check with your doctor first before we take anything that comes from not a pharmacy. All right, let's check first. Okay, so that's drugs and diet. I wouldn't go into that because that's why we have a whole team of speakers coming behind me. But diet is going to help us to control our pressure, our sugar, our cholesterol, and feel better. E is exercise, extremely, extremely important. It looks simple. Every little bit counts. Every little bit counts when it comes to exercise. We both want to walk, and we want to do some resistance as well. Resistance meaning some weights, some dumbbells. That's exercise on a whole. And S is to stop smoking. I am yet in my medical career to find any positive that comes from cigarettes. If you can find one right now, I challenge you to stop and interrupt me. No. For those online, no one. Okay. So targets, you would realize that when I went through the alphabet just now, I didn't mention a number that your blood pressure should be. I don't know if you were listening for that. I didn't mention a number that your blood sugar should be. And it's not because I forgot. It's because it should be individualized. Everyone in here should have a number that is specific to them, agreed upon with your medical team. It might look like some of you have the same targets, but it's going to be individualized. So at your next doctor's visit, I want you to make a point to ask your doctor, what should my A1C be? What should my blood pressure be? What should my cholesterol be? Your exercise should even be individualized, and that's why they're exercise experts. How much should I be exercising? What should I be doing? So lastly, let's round out the presentation by considering what should you do if you had a stroke, right? Because we're looking to the future. You may have, like my friend, gotten it wrong in the beginning. He unfortunately had an allergic reaction to his blood pressure medication, and it was quite serious, and he was quite right to be scared, but what he should have done, and he admitted to me, was to have a conversation about what else he could have used. So instead, he went over 10 years without being on medication, and over 10 years without checking his blood pressure. So the only time he checked was unfortunately the day he went to hospital. So if you do get a stroke, what is your mission? Your mission is to try to reduce the damage and to prevent another one. And who's in charge of that? The team, right? That's why we are here at this symposium, and it's a team, and this team effort is coordinated by the medical doctor, or if you're in Barbados, you're fortunate enough to have a specialist called a physiatrist. That person coordinates all of your care, coordinates between your doctor, your normal doctor, your GP, the occupational therapist, the physiotherapist, the nutritionist, the speech therapist. That person coordinates your entire care, so that person really should be a part of your management if you've had a stroke. Let's hear from my friend. I like talking to him.
I think for anyone that's not a natural. So I feel my face, I feel my left side, I'm both flat numb, and I show for help.
So he did exactly what he was supposed to do. So he recognized that he fell. Why would he fall all of a sudden, right? Probing later, he fell because the left side was completely weak. He couldn't put any weight on it. When he touched the left side with the right hand, everything felt numb. He couldn't feel anything. And what did he do next? He called for help. So he did what he was supposed to do. So take home number 3 is recognizing the stroke, because this could be the difference between a good outcome, an okay outcome, and a not so good outcome. So we need to be able to recognize it, and we need to think fast and be fast. So point number 3, if we're writing, this is what we want to write, fast. So F is for face. So this is facial twisting. So in Bajan parlance, your face look funny, right? A is for arm weakness. Now your leg could be weak as well. Well, what do? We ask them, put out your hand, let me see something. So you put out your hand. Or maybe they can't raise it at all. That's the A. S is slurred speech. Tell me what's happening. No, I can't mimic slurred speech so good. But what they can do, what some people can't do, is get out any words at all. So there's a change in speech. So if something's wrong with their face, F, if they can't raise their arm, if their speech is different in any way, then it's time to call 911. What's the local number here? There's another quiz. 511, correct, excellent. 911 will work as well, but it will take a little longer, so call 511. We'll ignore the 311, yes. Next. So when we're trying to prevent a stroke, so say you've had a stroke like our friend and you're trying to prevent another one, the first 30 days are most critical. And in those 30 days, the doctor is going to pay attention to what? Your A, B, C, D, and E's. Most important in that early period is going to be the B, the blood pressure, so we're going to be very interested in that. The drugs, we want to make sure you're on the right medication to prevent another stroke. And your rehab program is going to be very, very integral in those early stages. So what is he doing now to reduce his chances of having another stroke? What are you doing to try to stop yourself from having another stroke?
But keeping the blood pressure under control and the stress, got no on the stress level.
No prompting from me, I promise. No prompting. So he's got the message. So his blood pressure is now under control and he's managing his stress. And in a holistic rehabilitation program, stress management is actually one of the tools. So stress isn't just a word that we call when we are, feeling offset. Stress is actually a real part of holistic management. So what are his blood pressures doing now? So you said you had high blood pressure before the stroke, and unfortunately you didn't take your medication because of an allergic reaction that you had, and you also didn't used to check your blood pressures at home. Now that you've had this stroke and you're back at home, do you check your blood pressures now?
Every minute.
And what numbers do you see when you check your blood pressures?
Very good numbers.
What is very good? So I cut him off there. And when he says every minute, he almost is doing it every minute. I had to tell him just tone down a little bit, all right? And his numbers are absolutely excellent, less than 130 on 80. So he's doing very well, and he is actually getting a holistic approach to his management. So takeaways. One, there are two types of stroke. There's a brain attack, there's a brain bleed. Why is that important? Brain attacks get aspirin, brain bleeds do not. Excellent. The other thing we're going to take away is that there's some things that we can do to manage a stroke ourselves and some things we can't do anything about. The ones that we can do something about, we bring out the alphabet, and let's run through it one more time, and I want you to shout it out. A? Excellent. Well, the answer was there, but fine. B? C? There's a trick one now, because D is two things. D? Diet and drugs, excellent. Medication, that comes from your doctor. E, my favorite, and S, my work here is done. Thank you very much.
Thank you, Dr. Curtin. Are there any questions now? I don't think there should be any questions. She was so clear. So, of course, a question. I want one question from the floor. Welcome, morning.
Thank you. Good morning to all.
Hi.
Doctor, it is often said that if you have a stroke, there's a second one around the corner. How real is that, and is it preventative?
So that's exactly, they took it on already. So that's exactly what we would have mentioned. So it's a real thing, one. So two aspects of that you're probably getting at. So sometimes people come in with, I'm going to mention a fancy word right now, which is stroke and evolution. So some people come in and initially they can move their hand and they're talking just fine. The face just looks a little twisted. But then in about 1 to 2 days, they can't move the hand and the speech is gone. So that was a stroke that kept on evolving. There's some people who come in and the stroke is done. Whatever they've had at the beginning, they've had at the end. Now, you do have a high risk of having another stroke. The first 30 days are very critical. The first 3 months are less critical, but important as well. And then the first 1 to 3 years. So within that first 1 to 3 years, to answer your question, is when the risk of having a second stroke is highest. But once you've had a stroke, period, you have an increased risk of having another stroke. And what you can do to prevent it, to answer the second part of your question, is pull out the alphabet. All right? Thanks.
Thank you.
No problem.
Good morning again. My brother had a stroke about 10 months ago,
Sorry to hear.
and he was improving. He has been improving, but recently he had a seizure, and they tell me that it's all part of, it comes with the stroke. Can you tell me a bit about that, how
Sure.
it works?
Sure. Excellent question. I was tempted to put that in, and then I took it back out at the last minute. So when you've had a stroke, if we pull back up, oh, they took it down already. So remember those two images that I showed you, the brain bleed, the white stuff, and then the one on the left where it was very, very dark. Now that's tissue in the brain that wasn't there before. Blood shouldn't be in the brain. So let's deal with the brain bleed first. I'm not sure what type. Bleed, most like that's why I went with that first. So the blood shouldn't be there. And our body is very, very sensitive. Anytime something is there that shouldn't be there, we get irritated. So if something brushes our skin and we don't like it, what do? We scratch. Blood shouldn't be in the brain. So the body's response to blood in the brain is to be irritated, and it usually responds as a seizure. All right? So with time, as the blood is absorbed, the chances of you having a seizure should decrease, but there is that risk of you having a seizure once you've had a stroke. Similarly, if it was a brain attack, so it was caused by a clot, again, that dead tissue shouldn't be there, and that could irritate the brain and cause a seizure as well. So both types have a risk of seizure, but we find that we see it more often in brain bleeds or large brain attacks. Okay?
We can take one more question. Oh, okay.
Excellent. How much chemistry do you want me to get into? So A1C stands for glycated hemoglobin. So we have blood that goes through our body. You ever heard somebody ask you, what's your blood count? Right, so that's asking what your hemoglobin is. And what happens is that if you can imagine sugar trying to get around the body, the sugar attaches to your blood, almost like a ZR, right? But unlike the ZR, it doesn't get off until the ZR parks permanently. So until the blood cell has died. So what happens is that the sugar needs to get around the body. It attaches to the blood cell, and that's your sugar hemoglobin or your glycated hemoglobin. And when that ZR parks permanently, so it's gone in the shop for good, because our blood cells only live for like 90 to 120 days, is when that goes away. So if we have a little bit of sugar in the van, that's a good thing, right? And it reflects how long our blood sugars have been that way for the last 3 months, so for the length of time that the van was out traveling on the road. So A1C is used to tell us how good our blood sugar is or has been for the last 3 months, versus you going to the doctor and getting a finger stick. As I know some patients try to, I don't want to say cheat the system, but think they're a bit smarter than we are, so they fast the night before, they don't take any mangoes for like 2-3 days, and they go in and this blood stick is excellent, it's 5. But guess what? I'm going to do your A1C, and it's going to be 10. So I know that for the last 3 months, you were eating mangoes. Sorry to call that, but they're in season right now. You were eating mangoes, and your blood sugar was actually 10, 11, 12. And you've now come and tricked me, take your medication for 2 days, and your fasting is good. So the A1C is a reflection of how good your blood sugar is or has been. All right? There was a follow-up.
preventative medication. Is there anything else besides the medication? Because now, whenever we said he's giddy, I was like panicking. Do we have to take you to the hospital? So is there anything else besides the medication that we should do or can do?
This is to do what? To prevent a stroke or to help with the seizures?
With the seizures.
Okay,
With the
so you
seizures.
are delving into a medical consultation. So we're going to talk afterwards, all right, so I can direct you better.
All right, thank you.
No problem.
Okay, again, thank you, Dr. Curtin. So the journey has begun. So for someone, unfortunately, they've had their stroke, and they have to be actually admitted to Queen Elizabeth Hospital. Chances are, if all things worked out well, they'll be admitted to Ward C10. So now, we're going to speak to someone who is stationed at Ward C10. I'm going to invite now, we call her Sister Christine King, Nurse King. Mrs. Christine King is the nursing officer at the Queen Elizabeth Hospital. She currently manages the stroke unit, which we call Ward C10, and was very instrumental in its setup in 2014. She holds a bachelor's degree in nursing from the University of the West Indies Mona campus, which that program is affiliated with the Ryerson University in Canada. Her nursing experience spans several areas, including medicine, surgery, neurosurgery, ear, nose, and throat department, and gynecology. Ms. King has a very special passion for women's ministry and is a member of the leading ladies of the Koinonia Sisters. She can explain that to you later. And the International Prayer Altars. She's also passionate in visiting the sick and the elderly in the community. So right now I want to welcome Sister Nurse King.
Good morning to one and all, and the word is Koinonia Sisters. Yes, particularly happy to see all of you this morning. What I'm going to deal with is the role of the nurse in stroke management, and I was told to keep it simple. You may hear me mention one or two things that Dr. Curtin mentioned before. Don't get tired or bored. It's just reinforcement. When you hear things over and over, it's reinforcement, and then you won't forget it. But it's not that many that I will mention that she has already done. So I will indeed look at the definition again of stroke, and it says it is clinically defined as a neurological syndrome characterized by acute disruption of blood flow to an area of the brain and corresponding onset of neurological deficits related to the certain area of the brain, which is...
I'm sorry to interrupt this wonderful presentation.
Yes.
But the police need something done.
Oh.
The drivers of S8323 and the driver of XB3005, we really need you to move your vehicle immediately. So I don't see anyone moving, so I don't know if there's nobody in here. S8323 or XB3005. No one? Okay, continue.
Okay. Right, so it's a break in the continuity of the blood flow to the brain, simply put. And just to reiterate, next slide, there are generally two types of strokes. That's the ischemic and the hemorrhagic. And you have already heard that and the reason why we want to pinpoint which type of stroke a person has, there's an algorithm that you go through when there's a suspicion of a stroke, so that Dr. Curtin said you get aspirin or not get aspirin. But when you come to the hospital, and you are diagnosed, or you have that CT scan and you're diagnosed with a hemorrhagic stroke, then you would not get that swift treatment. But if you have an ischemic stroke and you meet certain other criteria, you can be eligible for something called TPA, which is alteplase, a blood busting drug, which can reverse the signs and symptoms of the stroke almost immediately. Before I get to that point, though, I want to reiterate the FAST, the acronym FAST, and we can put B before it, B FAST. And the B stands for loss of balance, and that's why Dr. Curtis would have mentioned too that you fall. There is a myth as to which comes first, the chicken or the egg. Does the person fall and then catch a stroke? Or do you fall as a result of having the stroke? Right? So the E is the eyesight changes. You might start to get blurred vision. You might even have lost vision from one side of the face, one side of your body, and you might find that a person then cannot see on the affected side, but they see on the other side. And me, as a nurse on the stroke ward, I've seen an interesting phenomenon in that the patient might be feeding from a plate, and they eat only from one side of the plate because that's the side they can see, and the other side, they're totally oblivious of it. Facial drooping, as was mentioned before, is the F. And I'm going to go through these quickly. Arm weakness. And as she also said, you can have leg weakness as well. And it's usually on one side rather than bilateral. It's not usually both hands go weak or both legs go weak. It's usually on one side of the body because the side of the brain that is affected, there's some tracks that lap over or cross over, and the right side of the brain controls the left side of the body, so that's why you might get a right-sided brain attack and a left-sided, I'm doing the opposite, the left-sided weakness. You understand what I mean? The speech, she also mentioned, can go funny. There's lots of different identifiers of the speech difficulty, but I will just leave it as speech difficulty. And she also mentioned that you can call, when you see those symptoms, that's the time to call 511, not 911. 511 is our ambulance. And it is important that you know to call the ambulance indeed, and not try to get the person there yourself, because of the speed in which we want to see this person get relief. A stroke, an acute stroke, is treated like a gunshot wound or a stab wound or so on. So the important thing is to get to the hospital, and the treatment will start from in the ambulance, and the ambulance personnel would be coordinating and relaying information back at the hospital so that things are prepared for them beforehand, because time is of the essence. For as fast as the slower you get to start the treatment, the more brain cells are being lost. So time is of the essence. There's a 3.5 hour to 4.5 hour window in which, remember I mentioned a blood clot busting drug, that if you meet the criteria, you can get it and you can relieve those symptoms. It does not always happen, but there's that good possibility if you're a young person and you've been in the workforce, and then to all of a sudden lose your function. So we try to alleviate that so that you can have the smallest possible, if possible, effects from that stroke. Okay? And I want to plug in here as well that the time of the onset of the stroke is counted because it is important that if a person was asleep and then wake up in the morning with the effects of a stroke or the signs of a stroke, you cannot really estimate when that person started to have the symptoms. So it's important that the doctor will ask, when did it start? When did the symptoms start? If you see the person, the plate drop out of their hands while they're eating, or if you actually witness when the speech became slurred or whatever, that is a good way to measure the onset. But if they were sleeping, you cannot give that drug because you do not know the time. If it's too long a period, you can only kill them if you still try to give them that blood clot busting drug. Understand? All right, so next 2 slides. This one. So I just want to also mention who is on the team. I'm on the stroke unit, and we have the neurologist and registrar, that's the doctor responsible for dealing with the strokes. And you heard of the physiatrist, he's responsible for the rehab arena, and a part of those other parts of the team are the physical therapists, occupational therapists, and SLP means speech language pathologist. Some of you may not have even heard of that, but that is one of our members of the team as well. The medical team, which is headed by a consultant, and then their team of doctors. Nurses, of course, dietitians, a social worker is attached to the stroke unit. There is, I often, when I do these presentations, I put psychologists in red to show that we don't have a psychologist, but there should be one. And there is I got physiatrist choice, that shows how important he is. And there's the pharmacist. We do have a pharmacist attached at times. Next slide. And you don't have to go back, but I just want to mention that the stroke unit is the most common part that you would find multidisciplinary care for our patients. And on Thursdays, we all get together and sit around, except for the medical team. All those other entities I mentioned, we come together planning the care for our patients. According to the National Stroke Association, this was kind of important to me, so I thought I would include it here. 10% of stroke survivors recover almost completely. 25% recover with minor impairments. 40% experience moderate to severe impairments that require specialized care. Next slide. And 10% require care in a nursing home or other long-term facility. 15% die shortly after the stroke, and approximately 14% of stroke survivors experience a second stroke in the first year following the stroke. Next slide. Successful rehab depends on the amount of damage to the brain, obviously, the skill on the part of the rehab team, the cooperation of family and friends, and we focus a lot on family involvement in the care of the stroke patient. And while you're on the stroke unit, we do some teaching and coaching and so on with the relatives, so that when the patient has reached the level that they can go back home, the relative is not at a loss and don't know what to do with their relatives, do not know how to help care for them. So we all come together and help in that process. And the timing of the rehabilitation, the earlier rehabilitation begins, the more likely survivors are to regain lost abilities and skills. Next slide. I'm on a timer. The role of the stroke nurse is to liaise with the multidisciplinary team to facilitate and coordinate the plan of care for all stroke patients that enter the unit. They use the certain assessments They provide patient and family education with respect to the diagnosis, treatment, and the secondary prevention, and they educate nurses. New nurses come on the unit, they learn about the practice as well, so there's continuity of the care. Next slide. Our focus is on continued stabilization of the patient, so we treat high temperatures, high blood pressure, high glucose. We evaluate the neurological status. We manage the blood pressure, as you see with the gentleman in the previous presentation, and prevention of complications. And what are some of these complications? Next slide. Aspiration, pneumonia, I'm just gonna name them. Hemorrhagic transformation that was mentioned before. Dehydration, when the patient has lost the ability to swallow safely, that can be an issue. Malnutrition and falls. Sometimes the patient doesn't even remember that they have a weak side and still try to do the things as normal. You have to sometimes keep prompting them, or they don't even realize that they have a weak side and still try to get up, and then they fall. Others are things like pressure ulcers, urinary tract infection, and especially because there's sometimes incontinence, constipation. We do not want our patients to strain at all to raise the pressure in the brain further, so we deal with constipation, and constipation can be a real thing because the patient is now lying in bed, can't move as they used to, so their bowel movements may change, their habits might change. Seizures, have you heard? We're going real fast. Seizures, have you heard? I get the message. And deep vein thrombosis, because the patient is laying in bed and then there's a risk that they can get clots forming in the legs and going up, causing a heart attack, a brain attack again, or a pulmonary embolism. Next slide. So I'm soon done. We deal other effects, emotional lability, which is the inappropriate or prolonged emotional responses to given situations. So you might find the patient, as soon as you go and say, "Good morning, Mr. X, good morning," the patient just lose out in a cry. You wonder what's going on there. It seems inappropriate, but they just can't control their emotions at that point in time. And sometimes if you do not know, you may get frustrated with the patient, but we are trained, we know. And the nurse must help family members to understand that this is common and help them not to become frustrated. Next slide. You can get post-stroke depression, which is a big thing. It may affect up to 40% of stroke patients. And it affects the body, the emotions, thoughts, and mood. Imagine you up and about doing all you can for yourself, and all of a sudden you have to depend on somebody. It's like one hand and one leg tied, and you can't move them at all, but you still have to try to function as though it's normal. So all these things can bring on depression. Next. Nurse, that's me. Supporting the patient. Next slide. In closing, stroke is a complex, and the road to recovery can be long, certainly hard work. With trained specialists in the field, stroke is a very interesting and rewarding condition to treat, not that we want you to get strokes. Next slide. Thank you very much.
Sister King, don't move too far. Are there any questions that y'all need to ask right now? Don't feel shy. The mic is in the middle. Everything is clear, clear, clear. Yes? Okay. Thank you, Nurse King. So, let's continue. So you've had the stroke. Unfortunately, you've been admitted to hospital. You've been admitted up now from A&E up to Ward C10. You've met the nurse. You see Nurse King. She's having a conversation with you. She's telling you how to take care of yourself. She's calming your nerves. She's making sure her team administers medications. And Dr. Curtin mentioned, you know, you've had a stroke, so we got to really look at how the medication is working within your body. Some of us in Barbados, we like to start talking about turmeric and stuff. We're doing drugs, medical drugs. Don't ask about turmeric, don't ask about all these other things. We're going straight and medical today, right? So now is the opportunity for us to actually talk about the drugs. So I see our pharmacist has stepped out right now. So shall I quiz you all again? What's A? What's C? What's D? So let's talk. So we're going to have somebody talking to us about diets. Do not ask her about pigtails. Do not ask her about fried chicken. Okay? We're going correct today. What letter did I miss out? Exercise. If there's one thing about physiotherapists, we're going to talk to you about exercise, exercise, and exercise until you're tired. There are some patients in here that may say, I am so tired of the physiotherapist giving us these exercises. But you know what? The exercises make you function. The exercises allow you to move and do all the things at home. We don't want we're independent people, and we don't want person to be helpless all the time. But you know, if we exercise, it makes a big difference to our function. So I see that our wonderful pharmacist has stepped back into this. Welcome. So right now I want to welcome Mr. Robert Carter. Robert Carter is the head of the pharmacy program at the Barbados Community College. You can hear me properly? Good. He is the coordinator of the pharmacy internship for the Barbados Pharmacy Council. He began his professional journey in community pharmacy practice with Nike's Pharmacy, not Massey, don't get confused. And in the 90s, and that was in the 90s, and in the early 2000s, worked with two pharmaceutical firms, which is Novartis and later Carlyle Laboratories. In 2006, he became a part-time lecturer of pharmacology, and in 2010, became had a full-time career in academic pharmacy. Mr. Carter has done local research on the practice of pharmacovigilance in Barbados. Though the monitoring of drug adverse reactions continues to be a paramount concern for him, he remains passionate about living an illness-free lifestyle, which we all want, promoting natural, healthy lifestyle choices as a major preventive measure against the diseases, morbidity, and mortality. So we will welcome now Mr. Carter.
All right, good morning to everyone. I have but a short time. I'm going to try to make the best of it. Now, just some recap. I'm going to probably make Andrew and Alex a little busy because I'm going to move around, especially with relation to this. So thank you to the media team. Now, this morning, I was listening while I was coming in the car. Now, I want to see a show of hands of those of you who are here who are non-medical persons. Just want to see the show of who we're talking to. Good. Good. I was told that there will be a lot of non-medical persons, so I would like to direct my presentation in that direction. Now, I'm going to take the mic out. Good? All right. All right. Just going to move the little gifts here. Now, what I wanted to do, the first thing I wanted to do is to ask somebody one or two questions. One, this morning, Dr. Curtin was talking to you about the use of aspirin. Anybody can remember what she said about the use of aspirin in stroke? What type of stroke would the physician prescribe the aspirin for? Not you. For what? Brain attack. Pardon? The ischemic. What that means? I want the big words. Huh? A blood clot and not a brain bleed, right? All right. I think if we can just get you to progress along, yes. So you have the two types. You've learned that this morning. Let's move on. I think I probably have a picture of the ischemic type and the hemorrhagic type. Let's go on. And we know that it's the fifth leading cause of death across the world. Let's move on. I only have 10 minutes. A lot of people are unaware, however, that diabetes is a main cause of stroke or risk factor for stroke, and a lot of people are unaware that they have diabetes across the world. Let's go again. Risk of stroke is 2 times higher when you have diabetes. So that's a risk factor that's very important. All right, let's go again. All right, so I'm going to ask a question. I want somebody to come up. I'm going to just put this model up here. This is the first model. All right, let's leave that on because that one, the lung collapse. So we leave that. I want somebody to come and find the pancreas. I want the pancreas. You're taking too long. They told me I only got 10 minutes, so let me call you. The darkest thing there? Which is what? Not this. What is the heart? What's this here? The darkest thing here? This is the pancreas? This is the pancreas? That's not the pancreas. Where's the pancreas? I asked somebody to come up, you know. Y'all shy? Come. Sit here. Yes. This is what I do in classroom. I pick on you when you don't want to volunteer. That lung collapse, you can step on it. What's this? This is pancreas? This is the pancreas? All right, listen, tag somebody. I ain't going back down. She did a good job. She said, I would have thought it was the pancreas too in another life. But let's go find the pancreas. You tag somebody. Right? Listen, come, because you telling me about the dark, so come. She looking back now, look. Come see if you find the pancreas. I see it already, so it's exposed now. You got to point at it. Let me see.
Okay, so here.
Yes, it's somewhere there, but it's right in front of you.
Yeah, but
Look good. You could if you want. We got to take out the whole thing. Look.
Okay.
Look, let me see where you find it now. You mean the one up in here?
Yeah.
No, that might be the spleen. Look at right here, look. It right there, look. Look at resting on top of the intestines there, look.
Oh, this is it?
That's the pancreas there. Yeah. That's what you're sorry about. I did this with purpose. Thank you very much. Give her a round of applause. What's the importance of the pancreas? It is from, you didn't see it? It is from the pancreas that the insulin, I'm giving you the whole and you want to pass it around, it's fine. It's from the pancreas that the insulin is derived, yes? That's where the insulin comes from. If you spike your blood sugar, if you eat something, sugary, carbohydrates, whatever, then the pancreas is going to release insulin. Let's move the slide along. So we know that the pancreas produces insulin. Go again. And the insulin is necessary for something, and this is where I want. Now, this morning, again, and I like the presentation. I like both presentations, as a matter of fact. I don't want to say I like one over the other. But this morning, I heard Dr. Curtin talk about hemoglobin A1C, and that's where I want to place a little emphasis. Have you heard of the term insulin resistance? What is it? Good. Now, I built this for one. My students had a symposium at Ross, and I built this for them to take over there and do a demonstration. And I asked Trudy's little girl to lend me some toys. I want to demonstrate insulin resistance. So this is what you see. It marked blood flow. You can see it, right? Good. This is red blood cell. This is some other kind of blood cell. And then I can put in some things in here. So in here, I have some keys. You see the keys? Yes. Those keys are neurotransmitters. And if it's a key, it means it's got to go into a keyhole. So every neurotransmitter has a receptor. All right? Norepinephrine binds to alpha and beta receptors. What? GABA binds to GABA receptors. Dopamine binds to dopamine receptors. What does insulin bind to? Oh, you're so good. That's one of the easy ones. What does acetylcholine bind to? No. Nicotinic and muscarinic receptors. You're trying to trick the system. Not in this exam. All right. And so have that in here, and you have it here, what you see an ion channel, and you see here insulin receptor. See the keyhole? Yes. So you come along now, this is blood flow, and these things are traveling through the blood, and so on. And you got some other things traveling through the blood. So I can make something here now. I hope that they can use this one. Good. Some other things traveling through the blood are these things here. drop some in there. You know what those are? Cholesterol? Yeah? You're almost right. I'm going to put some of the Play-Doh on there. You see the Play-Doh? Yes. What does the Play-Doh represent? It represents fatty deposits. You know the problem with insulin resistance? A lot of the times is diet and obesity. And so therefore, when this receptor comes along, whatever this is, and it goes to bind there, it probably won't bind because it don't belong there. That's probably dopamine or something. But this one here is insulin. You realize when you get to the keyhole, now the keyhole blocked. So the glucose cannot enter the cell. So your glucose stays in the bloodstream. Yeah? And the problem with that is that that's not necessarily a problem of type 1 or type 2 so much, you know. That's a problem. Because you can be obese and just have blockage of your receptors, and you're going to have increased blood sugar. You follow what I'm saying? But it is a big problem with type 1 and type 2 diabetes. And so for those of you who may have the, thank you, Trudy. Those of you who may have the issue of this, you may need to exercise and diet and try to work it off and walk it off, go around the gymnasium and do a couple laps so that you can get off the fatty deposits so that, where is it? It's right there. Looking for the insulin. It's in the truck? It's still in the truck? Or behind it? Or listen, where have it? Is it here? Empty the truck. Here, load the truck. Is it yellow? Maybe I put it in my pocket. Let me see. Yes. Thank you, here. Oh, I was getting worried there. Because you know they say that the thing leads, it interferes with your brain cells and leads to dementia too. So you put the thing in here, when you put the insulin in here, the door open, the sugar can get into the cell, and those who did biochemistry and thing biology, glycolysis will take place. Energy can be derived. Yes? Yes. But if it can't, if this insulin can't get there, you could take as much dimercaron as you want. You would sing him a ton, and you can't get that off. You will need metformin to help you with that. But you can't get that off, that's a waste of time. You follow what I'm saying? All right, so I wanted to use that little demonstration. I'm probably not going to get through all of my slides. I don't even know what's next. You can go to the next slide. We go again, past that, go again. And we dealt with this morning. And know that if you dial 911 here, it will put you to the emergency service. So don't fight finding 211, 311, and 511. Just dial 911. They can get straight to emergency services in Barbados. It works all across the world, including at Cable and Wireless and the other one. Next slide. Other signs that you may experience is numbness, confusion, trouble seeing, difficulty walking, and a very severe headache. So you know, I just lost a classmate of mine to a stroke. I just buried it like 2 months ago. This is very serious. All right, so some of the ways to prevent this is by healthy lifestyle choices. Get your weight down. Start to exercise, eat healthy. I heard Dr. Curtin tell you that she doesn't know the benefits of smoking. I will say it like this. I know that Bajans does run, to fire. But I never see a Bajan go in a house that's burning and take an inhale. So why you inhaling smoke? Why you doing that to yourself? You understand what I'm saying? You don't usually normally do it. I got the same philosophy with the sea. I don't go in the sea because I don't see fish coming here walking boat. So, it's very true. Limit your alcohol and manage your stress. Now, go on in. Now, I wanted to talk to you about the glycemic index and the glycemic load, but the good thing about it is that the presentation will be left. So what I want to do is just slide along, just slide along, slide along again, slide along again, slide along again. Once a day, it should be on the camera. Slide along again, and slide along again, and it's going to be there for you for eternity on YouTube. Slide along again. Go again. Is there any more? There should be something else there. Stop. And this is probably the last slide, the benefits of low glycemic index foods. Now, somebody give me one example of a low glycemic index food and a high glycemic index food. One person, quickly. English potatoes is high, sweet potato is low. Now, that's a good example. Why is that? Why is sweet potato a low glycemic index, low sugar intake food? Because it's rich in fiber. That's a very good answer. All right, so I have something here. You ever see one of these? Yeah? A jam-filled one. That must be the nucleus in the cell. So what is it that's residing on the outside? Sugar. You remember this morning? Oh, sorry, Alex. We'll come back in this shot for you, right? You remember this morning? This is the last thing I'm going to talk about. You remember this morning, Dr. Curtin talked about the hemoglobin A1C? And she told you that you must try to get your hemoglobin. It gives you a better picture of your state, your glycemic state. Well, let me explain what happened. Because they got a lot of people that they just eat as they like, right? And then 2 weeks before the doctor visit, they just go and eat all the low glycemic vegetables and all those things. And guess what happened? When they go and see the doctor, they got what? They got like 7 point something or 8 point something. It's nice and good, 7 point something, 6 point something. Not bad. And then they're telling you, yes, doctor, praise Jesus, I've been eating healthy. And they come and testifying. And the doctor go and order what's called the hemoglobin A1C. I can explain that to you in detail. I got 1 minute left now, 2 minutes. I got no minutes left. I'm out of time. 30 seconds. I'm going to explain this to you real quick. So the doctor orders the hemoglobin A1C, and this is why you can't trick the doctor, and I want you to know, because you're only making yourself shame and going to the doctor's office. The hemoglobin A1C measures the percentage of glycosylation on the cell. Just imagine this was a plain donut. That would be a red blood cell. You see all of this sugar on here? That's the glucose stuck to the cell. This is the best example to explain glycosylation and hemoglobin A1C. And what this does is gives a measure of what you have been doing for 120 days. How many months? 120 days is 3 months? Leave my classroom. She gets 0. My classroom. 120 days is how many months? Thank you, here. I was getting scared. That's sometimes where you get the micro and they say repeat by 3 because you get a 4-month visit. You come back, I want to see what you've been doing for 4 months. So when you come in there talking about, oh, praise Jesus and things, doctor saying, I've been church event. Don't do that. You know you're eating bad because the thing got 19% hemoglobin A1C, all 12% and all kind of thing. You can't trick the doctor with that hemoglobin A1C, and it gives a better representation of your health. I am fully out of time. Normally A1C. All right, so 5.7 and below is normal. Between 5 point, this is percentage glycosylation. So this is too much, really. Between 5.7 and 6.4 is pre-diabetic, and above 6.4 is diabetes. All right? All right, so if you're in the pre-diabetic, you know you got to do some work. If you're diabetes, well, you're there already. Now, I'm fully out of time. I have to get off the stage. I only had 10 minutes. But if there are any questions on drugs, if there are any questions on drugs that you had, you can probably write them down and refer to me later with regard. Since she's gone, let me tell you quickly. Anybody here on those statins for cholesterol? It's something I really want to tell you about the statins, the cholesterol medication. You know, the Mevacor and whatever the statin is, atorvastatin and mevastatin. This is very important. Now, there is not everything. The reason why we go and study drugs at the BCC, there's not everything you can walk in the pharmacy and say you're going to pick up this herbal medication and take with this. So you can't go taking St. John's wort with it. You got to reduce the deep green leafy vegetables. You got to cut that out. You want the cruciferous. Now, if you're taking the statins, it is important that you protect your cells. It is something that blocks the synthesis of cholesterol, and your cell membrane is made up of cholesterol. To go into the health stores and ask for coenzyme Q10, there are other phosphatidyl's that you can ask for. It sounds like a big word, but you can ask for phosphatidyl's in there and other things that can protect. But try to get the coenzyme Q10 and those things that will go along well. These complement the statins, but not everything does. So don't just go in picking up, consult.
No persons have questions to ask, but we have so much information to share that if we ask to leave the floor open to too many, we're going to be in trouble. Well, I'll just give Mr. Carter 1 minute to answer 3 questions, right? And I am going to answer the question. How does that sound? Sounds fair? Yeah. Mr. Carter? So I'm a patient. Imagine I'm a patient with a stroke. In January, the doctor gave me 1 tablet to take. 6 months later, I gone back. They give me 2 tablets to take. 6 months later, I know taking 3 tablets. That sounds familiar? Quickly explain why we went from 1 tablet to 2 tablets to 3 tablets.
All right, so a possibility.
1 minute.
One very dangerous possibility is that you went to a different doctor each time. And we have to do something called medication reconciliation. They had a lady that fell down at a church that's Alexis Church that I used to attend. And she, stroke patient as well. And she was given the medication and she collapsed in church. When I went to her house, she had the same medication repeated several times by the physician, by different physicians. She went to a polyclinic here, she went to a private one here, she went to another doctor here. That's a dangerous thing. The other thing though is, if you are, your medication is being increased, it's a possibility that your condition is not being managed properly and you have to add either antiplatelet medications, platelet aggregation inhibitors, or any of the others. There's aspirin, there's Plavix, we can go on with a number of them, but it might be a case of your health not being monitored properly, your condition deteriorating, and you have to add medications.
He didn't do too bad just now, right? Okay, so now it's time for one question. Go ahead.
Hold the microphone.
Good day, sir.
Yes, good day.
You mentioned coenzyme Q10. What about the person who uses blood thinners? I'm on Pradaxa, and then there are many things I'm told I'm not supposed to use, and it scares me sometimes. I'm also on the statins. So what does one do in a case like this when they're prohibited from using these different things?
You prohibit yourself. You like Marby?
No,
I like
don't
Marby.
use Marby. I don't use Marby.
Well, that's a good thing, because Marby is also going to thin the blood. So when you ask what can a person do, now I'm telling you for a fact you can use the coenzyme Q10 if you're on the statins, yes?
Yes.
But I'm telling you that there's some you can't use. So Marby is out, and the same thing, John's wort is out, and anything that either potentiates bleeding or causes bleeding, you have to stop. So, I mean, if you want to have a discussion, we can have a discussion afterwards, because the list is exhaustive. But I'm just giving you some of the common ones, yeah? So coenzyme Q10, for a fact, that's not I know the interactions, so that's what I'm trained in. And so I can tell you off the cuff that there's some things that you can't use, what you can use and what you can't use, so we can actually talk about that.
Very well, thank you.
Okay.
Okay, I want to thank Mr. Carter. I'm sure he's going to stay till the end of the session, so because I know lots of you have lots of questions. So for sure, he'll be here to answer your questions. Now it'll be opportunity for us to give away a little gift, a little prize. There's nothing more exciting than a little prize. So I'm going to ask Patrice, oh dear, Patrice to answer your question, because we've all been listening very attentively. So you answer the question, you get a gift.
Good morning, everyone. My name is Patrice Stowe, brand manager at Massey Distribution. Sorry. Yes, my name is Patrice Stowe, brand manager at Massey Distribution. I'm also a pharmacist as well. So my question today.
Make it hard.
Make it hard. All right. Can anyone tell me what is a CGM device? Have you ever heard of a CGM device? Okay. All right. So we just dealt with diabetes and glucose. Oh, I see it. That's correct. So for those of you who may be wondering what that is, so you normally would prick your finger to do your blood sugar reading. And I have two of those machines that you may be familiar with to give away. But the continuous glucose device, that is a more modern way of monitoring your blood glucose levels. And you would have heard Mr. Carter talk about the HbA1c, where the doctor would be monitoring your blood glucose for the past 3 to 4 months. Now, with the CGM machines, the doctor, sometimes the HbA1c can be a little bit not as accurate. So with the CGM machines, they get a more complete look at how your blood sugar has been controlled over that time, because it's, as I said, continuous monitoring. So when you're sleeping, once the reader for that machine is close to you, your blood sugar is constantly being monitored. And I don't know if this was mentioned before, but most persons who have suffered a stroke, the number one problem, I should say, when it comes to being newly diagnosed is you.
I receive. So it's for you then to, right, so for you to find that person in the crowd that you think is deserving of such. Dr. Warner is always very generous and caring. So I know when he answered, he was not going to take it for himself, he would share it with someone else. So thank you, Dr. Warner, and thank you. You'll be back up again. Thanks. Okay, so we've had this stroke. We've been told all about this stroke. We went to C10. We are ready for discharge. We've talked then about the medications which, we kind of talked about the medications which you will need when you get discharged. But we've been sent home and told, eat right. So you go home and decide, well, I can eat some cheesecake sometimes. I can eat fried chicken on Mondays, but not on Saturdays. I can eat pudding and sauce on the Fridays because I'm going to go to Golden Sands and get it, but I'm not eating it all week, right? Sounds familiar? But all that has to change. So coming to address some of these will be our dietitian, Ms. Sade Haynes. Ms. Haynes has been a registered dietitian for the past 14 years. She completed both her bachelor's degree in nutritional sciences and master's in human nutrition at McGill University. As a clinical dietitian, she works with individuals at every age and life stage, leading to diverse experiences and interests in the field. Her area of expertise, however, includes enteral nutrition support, intensive care, and nutrition education and counseling. She enjoys passing her knowledge and experience on to aspiring dietitians through mentorship, preceptorship, and as a part-time lecturer. She is passionate about the role of nutrition in the prevention and management of disease and to support recovery from illness. She's also a very strong advocate for the role of the registered dietitian in the healthcare team. She currently serves as the president of Dietitians of Barbados and is also a member of the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition. I want to welcome Ms. Haynes to the stage.
Thank you. Good morning to everyone. So everyone's aware that we're on time constraints. My presentation starts much like the first two presentations did, so I'm going to skip a couple of slides as well. So over here, I'll let you guys know when to do that. Not yet. Let's go back one. So first of all, thank you to Barbados Physical Therapy Association for inviting me to present this morning. Hopefully, we can get a little bit of knowledge on what a healthy eating pattern looks like, how to practice portion control and make some helpful choices, and a little bit on where you can find more information. So we're going to start to skip. You've seen this about 3 or 4 times, and skip again. So let's go with eating well to prevent a stroke. So whether you've had a stroke before or you have those conditions that put you at risk of a stroke, your diet is important. And what I want to focus on this morning is about dietary patterns rather than specific nutrients. So anyone in this audience will tell me you have to eat less salt, you have to eat less sugar, you have to eat less. Dietitians, we like to focus on the positive. What do we need to do more of? Dietary patterns are focused on our food groups. In the Caribbean, we have 6 food groups. These are our staples, so think about our starchy foods like ground provisions, breads, biscuits, cereals, green bananas. Plantain is a staple. Corn is a staple. Those are not vegetables. Our legumes are peas and beans, nuts and seeds, so think about lentils and chickpeas and black beans and anything else you like to enjoy. Our third group are foods from animals. These are our meat, poultry, fish, eggs, cheese, milk, yogurt. We've got fruits, which I think most people know what fruits are, and vegetables. And our last group is our fats and oils, which would include fatty fruit as well as like oil and butter and those. So there are 2 dietary patterns that have scored really well in terms of prevention of a stroke. And these are the DASH diet and the Mediterranean diet. So today I'm going to talk about the DASH diet. Next slide. So DASH diet stands for Dietary Approaches to Stop Hypertension. This is where it originated, but it is actually a diet that is beneficial for more than just hypertension because it really does follow a healthy eating pattern. It encourages our vegetables and fruits and whole grains. If you're using dairy, low-fat dairy, as well as our legumes. And the overall goal of the DASH diet is to make sure you're getting enough fiber, magnesium, potassium, and calcium in the diet while you limit your salt, sugars, and saturated fat, cholesterol, and trans fat intake. Next slide. By our Caribbean food groups, the DASH diet. Here are the foods that you need to choose more often. For our staples, we're focusing on our high fiber foods, so our ground provisions and our whole grains. For our vegetables and our fruits, these both provide us with our potassium, magnesium, and fiber, and any kind of fresh fruit and vegetable will do. There's no special food that you need to use. You don't have to buy a specific superfood that you learned about on the internet. Any fresh fruit and vegetable will do, and vary your colors. For our vegetables, we do emphasize using dark green, orange, and red varieties daily because of specific nutrients that those provide. But any color as well will do. Our foods from animals are major sources of protein and magnesium, and in terms of dairy, calcium as well. The emphasis here is to limit your fat, so you're choosing your lean proteins, your lean meats, removing any fat you can see, removing skin before cooking, and using low-fat preparation methods. So rather than frying our foods, broil, roast, bake, steam, boil, what have you. Anything that doesn't require you to add a lot of fat into your pot. For dairy, you're looking for things that are fat-free or low-fat. For our legumes, any kind will do. In terms of our nuts and seeds, raw, and that will allow you to limit your sodium intake. And these will provide you with fiber, energy, magnesium, potassium, and protein. And for fats and oils, so growing up some decades ago, I remember that fat was bad, fat is evil, and fat was going to kill us, right? That was the message, all right? But there is a value to fat in the diet. The issue is that it provides a lot of energy, so you don't need very much of it. So in terms of our fats, we want to choose wisely and limit the amount that we use. We focus on our healthful fats coming from our fruits and our nuts and fatty fish. So think about things like tuna and herring and sardines and mackerel and salmon. And our nuts and seeds, if we're using fats in our cooking, you're looking for fats that are liquid at room temperature, so that's our vegetable oils. So I did say that dietitians focus on the positive, but we do need to remember some caution points. So it's the opposite of what you've seen so far. Foods to limit or avoid, things that are fatty, so our fatty meats and full-fat dairy, as well as tropical oils. So coconut oil, you can see coconut oil looking solid at room temperature. It looks a little bit white, right? And that's because it's high in saturated fat. And saturated fat can raise your bad cholesterol, your LDL, so that's why we want to limit those types of fats. The other type of fat that we worry about is our trans fats. These are fats that are created on processing, and these tend to be found in things like baked goods and fried foods. And why we want to limit those? Well, trans fats raises your bad cholesterol, and it lowers your good cholesterol. That's a double whammy. The other things, limiting our simple sugar intake. So usually that comes from beverages and sweets. Limiting foods that are high in salt, and I'll show you how to identify that later. And I think alcohol has been mentioned maybe 3 or 4 times already for the morning as well. And that raises your blood pressure, so you want to limit that. So 3 takeaways today. I'm doing like Dr. Curtin. The first point, the second point. First point was our food-based dietary guidelines. Our second point is portion control. So we've seen in plate earlier, a very simple way to practice portion control. We eat from a circular object. We say let half your plate be vegetables, 1/4 for your protein foods, and 1/4 for your carbohydrate foods. And here are some examples. This is from the Caribbean Public Health Agency, CARFA. They've done My Caribbean Plate, because we've seen this image so many times, but it's always someone overseas, right? So now we can see what it looks like for our region. I want to draw your attention to the plate right at the very end with the pasta. The protein there at the bottom of that plate, those are lentils. So you can get your protein from your foods for animals or your legumes. And you can see there's a variety of starches being used, whole grains for bread, or high fiber ground provisions, and lots of vegetables, or reds, or orange, or greens. Some are cooked, some are raw. Really getting a lot of variety in your diet. Second way that we can practice portion control is to use our hands. Okay? We say compare your portion for your starch to your fist. All right? And our hands are proportional to our body. So I would use my fist for me, you would use your fist for you, and even if you have a young one at home, you can use their fist for them. Okay, so the fist for your starch, you can also use your fist to estimate your portion for your fruit. 2 handfuls for your vegetables. For your protein, so this is our meat, our legumes, our fish, and those, compare it to the palm of your hand. Not the fingers, not the thumb, just the palm. For fat, in order to limit your fat intake, you compare it to your thumb tip. So we've seen the DASH diet patterns, we've seen our portion control. The next thing we look at is the nutrition facts label. Who uses the nutrition facts label in the supermarket? Good job. All right, so some people find this confusing. So let's demystify the nutrition facts label. The first thing you should see right at the very top is your serving size. The importance of your serving size is that all the information on the label is based on that quantity of food. Here it says 1 cup. So if you ate 2 cups of this product, you have to double everything that's on this nutrition facts label. If you're interested in energy, then you look at calories. That's the energy we get from food. The other nutrients highlighted in yellow here are listed below that. And then this really interesting thing happens on the right side of the nutrition facts label, a percent daily value. And that's shortened to percent DV. And this is the quickest way that you can interpret a nutrition facts label using a percent DV. Next slide. Okay, so remember 2 numbers, 5 and 15. If you want to know if a food is high in something, if the percent daily value of that nutrient is 15% or more, that means a lot. If you want to know if it's low in something, 5% daily value or less, that's a little. It means it's low in that nutrient. And we demonstrate on the next slide. Okay, so this product, at the top, the highest yellow highlight that you can see, that's saturated fat. That's the one that raises our bad cholesterol. And the percent DV there is 23%. So we said 15% or more is a lot. So this product is high in saturated fat. The next highlight you can see there is sodium, 850 milligrams. Wow. Okay, and the percentage there is 37%. That's also more than 15%, so that is a lot. So this is not a product you're going to choose if you're trying to limit your fat intake and your sodium intake. For nutrients that you want to have more of, that are found below that dark line in the nutrition facts label, the blue highlight, no, let's use the yellow one. The yellow highlight for calcium, 320 milligrams. The percent daily value there is 25%, which is more than 15, so that's a lot. So maybe if you wanted to increase your intake of certain nutrients like calcium, then you can use that part to figure that out. Next slide. So I was very judicious with these slides. I even deleted one this morning. So I was asked to talk about the role of a dietitian. And how can a dietitian help me? Well, who are we? We are the food and nutrition experts in the healthcare team. We assess, educate, counsel, and empower. In terms of strokes, we can assist you in keeping your blood sugars in the safe range and keeping that A1C down when you get your result done in 4 months' time, lowering your cholesterol, lowering your blood pressure, and achieving and maintaining a healthy weight. For those who have had strokes, sometimes there are effects of a stroke that can impact on your ability to get good nutrition, so we can also ensure that the nutrition you get is safe and adequate. And we tend to collaborate with the speech-language pathologist on that. And then anything you do, you have to follow up. So we take a look at what's going on, what worked, and what didn't work, and make adjustments to that plan as necessary. And if you want more information on our Caribbean food groups and how to make healthy choices based on each food group, then, next slide, thank you, you can look for the Healthy Eating Guide for Barbados. This was published by the National Nutrition Center, and you can find it on their website for download, which is nutritioncenter.health.gov.bb. You can also get information from the Heart and Stroke Foundation Barbados or internationally American Stroke Association. What have you learned today? A healthful eating pattern may help lower your risk of a stroke, even if you had a stroke before. Choose vegetables, fruits, or high fiber starches, legumes, keep the proteins lean, and low-fat dairy, and the helpful fats more often, and limit those nutrients that don't really do much for us in terms of keeping our NCDs under control. Next slide. We can use our plates or our hands to practice portion control. You can use the nutrition facts label to help you make wiser choices, 5 and 15, and a dietitian can help you to make positive changes in your diet. And we do that based on your individual needs, preferences, and health goals. Thank you.
Thank you very much. So we have a minute for questions. So if you have a question, please come to the mic so the persons online can actually hear the questions. So while you wait for someone to come up, somebody's ready and raring to go.
Out of curiosity, you said no frying, and I understand that. But what about the air fryer? Is that a good?
Right. So,
as well as you mentioned coconut oil.
Yes.
I was also curious about sunflower oil as well.
Okay. So for the air fryer, I know it's very popular and trendy. And when you use the air fryer, as long as you're not using a lot of added fat to achieve your end result, then it can be a good substitute rather than deep frying or frying in the traditional way. In terms of sunflower oil, well, in general, for our fats, we say liquid fats versus solid fats as your predominant fat in cooking. If we think about dietary patterns like Mediterranean diet, we encourage oils that are higher in omega-3s like olive oil or canola oil, right? But beyond that, it's more important to limit the total fat that you're using in your cooking. So if you fry in a healthier oil, frying takes up additional oil into the food. You're adding energy, without adding any calcium or iron or any other of those beneficial nutrients. So we increase the energy density of your food rather than increasing the nutrient density of your food. And if you think about how you eat as, I don't want to use the word energy budget, but every time you eat, you want to get energy, but also some vitamin and mineral and some fiber along with it. So when you fry, you don't really add anything more to the product rather than extra energy. So with fats and oils, you need some. The thumb tip is approximately a teaspoon. You can maybe aim for about, well, it depends on the person, but you can aim for about maybe a tablespoon max. You're cooking and you're going to be sharing a meal, hopefully, and that will help you to kind of limit the amount of total fat that you take in. But this oil versus that, we think about budget and all those things, is more important to just limit your total fat intake.
Good morning. Actually, with your explanation to her, if I am cooking, the person, is it a tip of thumb for like the whole family, or just per person? So I like put 5 thumbfuls in for a family of 5.
I'm not going to answer your question directly. We're not going to do nutrition math this morning. What you can do is, if you have a non-stick pan, you do that. That helps you to limit how much fat you need to do the preparation. The other thing you can do is get the sprays. Okay. That can help control how much fat you add to the product. The rest, I mean, if it's not a non-stick pan, I can't tell you to burn out your food. but you could, if you want to approximate a tablespoon, it would be the entire thumb tip. It would be entire thumb, 2 knuckles. So okay. This thumb tip would be, you know, if you're spreading some margarine, a teaspoon of margarine on something, that would be about a teaspoon. But just techniques. We don't get into the nitty-gritty of numbers. It makes life a little bit too torturous. To cook, I have to count. Okay, that's 10 people, so 10 thumb tips.
Okay, yeah. Thanks for that. My question, though, if I am in food portions, and I'm using a plate, half the plate for the vegetables, but if all my protein is coming from legumes, and a quarter is supposed to be for starch and a quarter for protein, my legumes, how do I just say this is and forget the starch? Use the legume as a quarter and forget the area, the other quarter for starch? How do I do that?
Still put the starch on the plate. So the Caribbean plate showed the pasta, and then the legumes were filling the space of the protein on the plate. So
Okay.
if you're using your legumes for protein, still put some starch on your plate.
Okay, thank you.
You're welcome. That's it.
Thank you very much. We learned a lot there again. We are flowing. So we have been sitting a while. So there's nothing like physiotherapy and exercise, remember? So remember at school we tell everybody stand up. Those who can stand, please stand. And I went to Erdiston Model Mixed School, and we used to do hands upward stretch, hands forward and down. One more time, hands upward stretch, forward and down. And nothing like a 3. Last time, hands upward stretch, forward and down. Do a little march. Let's march 10 times. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Wonderful. You know, you could tell the persons who attend physiotherapy, even the ones that sitting, marching. We are doing a wonderful job. You can have a seat, everyone. So leading up to that then, since we've done a little physio, let me introduce our next speaker. Dr. Melissa Walkup-Husey. She's been a physiotherapist for 25 plus years and has worked in both public and private sector settings, treating both adult and pediatric patients in all aspects of physiotherapy. In 2017, she opened her private practice called Total Therapy, where she treats mainly orthopedic and neurological conditions using a holistic team approach. She has kept current in rehabilitation techniques, and in 2023, just last year, she completed a functional neurological mentorship. She's a mother of 1, lover of cooking, aging wellness, dance, and the beach. So you're welcome now, Dr. Melissa Walcott, QC.
Let me adjust this a little bit. I'm very tall. Good day, everyone. Today we're going to be talking about physiotherapy and stroke. As we've heard before, we know there are 3 different types of stroke, and we're talking about there are 3 different types of stroke. And as we know, we've heard that we have about 700 strokes in Barbados per year. So this is a very important thing that we know. I'm not going to go through this because we've had this spoken about a number of times. All right? The stroke symptoms, as you remember, one side of the body, drooping of the face. I think everybody is familiar with that from now. A stroke happens quickly, happens in a matter of seconds. However, rehabilitation takes a while. It is like a marathon, a long, arduous road with lots of twists and turns. It is not a straight line, and I'm here to tell you that rehab does not happen easily. It requires you to be constantly active, be constantly doing the exercises, constant visits to the physiotherapist, so that we can figure out where you are and how to help you get better. All right. Think of a stroke as, like if you think of the glass in the mirror here, something has hit one side, which is the stroke, right? So you can't see that side. That side is not functioning as it should. Therefore, the pathways are not working as they should. A physiotherapist's job is to figure out which pathways are not working, figure out if they're not working, if we can make them better, or if they're just partially broken, if we can rehabilitate them to work at their maximum. All right? And how do we do this? The first thing we do is we will assess you. All right? Assessment takes a number of factors and a number of things that we take into consideration. The first thing we're going to be looking at is your tone. We want to see what's happening in that limb. We know one side of your body is not working as it should. Is it flaccid? Does it have no movement at all? Is it stiff? Is it very tight? And each patient that comes into us is going to be in one of these sectors. And because you see the seven layers doesn't mean that each person is going to go through each one of these. Some people will come to us at stage number 5. Some people will come to us at stage number 1. But we need to figure out what stage you are so we can start planning for you. All right. The next thing we're going to be looking at is your bed transfers and your ability to move in the bed. We want to see how you're moving. We want to see how your family members are helping you to move, just to make sure that we're doing this correctly. And we're looking out for your shoulder that might be flaccid, because as we know, that flaccid shoulder can lead to problems in the long run. We don't want to injure it. We don't want to cause you pain in that shoulder. So we're making sure that we're doing things that you're doing things the correct way. We want to see if you can sit up in bed. We want to see if you can get out of bed. We want to see if you're able to walk, and if you are, what your walking is looking like. And this is all happening in our assessment phase. All right? We're going to ask you questions like, how are you eating? Are you able to feed yourself? How about bathing? What are the challenges you're having in these areas? Dressing, toileting, getting around. What are your challenges? Right? So once we have all that information, we're going to formalize a customized treatment plan for you. Every patient is seen differently, because as you know, no 2 strokes are alike, right? And that's a very important factor. No 2 strokes are alike. So once we've done your assessment, we're going to come up with a customized individual plan for you. All right. First thing we're going to start doing, if you have a flaccid limb, we're looking at things like modalities. Do we need to use electrical stimulation to be able to make sure that to get the limb moving again, whether it be the hand or the leg, right? If there's swelling, do we need to put tape? Do we need to make sure that we're keeping your leg in a particular position when we have you moving? All right. We're talking about things like getting the brain to remember where the limb is. So we're doing things like proprioception. So we're having you put the leg on the ground. We're making sure you know where the limb is in space. We're making sure that not only do you know where it is, that you can move it from one position to the next and know where you have moved it to. All right? We're doing that for both upper and lower limb. Right? We're talking about mobility now. We're trying to see, do you have full range in the joint? Right? Because it's very difficult to ask you to do an activity when you can't move the joint through the full range. If you don't have that, then we start training work with what range you have and start improving that. Right? We're teaching you things like safety. So we want to make sure that when you're getting up from a chair, you don't leave that flaccid hand behind you. We're teaching you things like holding it when you're going. We're improving your body awareness. All right? We're looking at your balance. As you can imagine, balance is one of the most important things for a stroke patient because half of your body is not working as it should. Right? And that's going to throw your balance off. So we're not only doing balance activities in sitting, we're doing balance activities in standing. We're also looking not only on you being able to balance, but your accuracy, your ability to do things with the balance. So you should be able to stand on one leg, yes, but if you put that leg down, do you know where you're putting it? Are you putting it in the right place? So these are a number of factors that we're putting into this. All right? Strengthening exercises. Everybody thinks of strengthening and they think automatically we're going to weights, all right? Unfortunately or fortunately, that's not how it works with stroke patients. Because the limbs are in various stages, we need to see what movements you do have. And sometimes an exercise for a patient may just be trying to squeeze their fingers together. It may be trying to move your toes while you're sitting in a chair, all right? So the therapist is going to look at what you are able to do, and then we're going to progress as we go on. So we're starting out slowly, we're looking at what's available, we're strengthening the patterns, and we're trying to create good, clean patterns. So we're trying to get rid of these unwanted movements. We're trying to get rid of, like if you ask a patient to bend their elbow and you see the hand go up that, we want to make sure that you can use each and every joint individually, right? Walking aids. So once we've gone to that point, now we're looking and thinking, okay, this person is able to get up and get about. What are we going to use so that they can get up and about as safely as possible? So we're looking to see what walking aid is available for them. We're going to not only determine which one, we're going to train you in the use of this walking aid, which includes things like height adjustability. Very often you see people just go and buy a walker or go and buy a cane from wherever, and the cane is too low and they're leaning over it. We're training bad patterns. And the one thing we want to do is not train bad patterns, all right? And then we get into one of our favorite topics, which is gait retraining. So very often we're starting in parallel bars, depending on where the patient has come into us. Sometimes we have to go to the nitty-gritty where we're doing gait retraining, where we're actually moving the leg for the patient. And we're going to be repeating these things over and over again. As I've said before, the rehabilitation does not happen immediately. It's a very slow process, but you have to keep doing these movements over and over again. The family members have to get involved, and we're going numerous times in a day. When you think of a child who's learning to walk, they don't just get up and walk one day. They spend months rocking from side to side, and you have to build back up those muscles. You have to build back up those pathways. These things are going to take a while, right? So then once we've gotten you able to actually do the moving, then we need to make sure that you're able to walk on different surfaces. We need to make sure that you can do obstacle courses so that you're able to walk not only in a straight line, but to be able to walk over things. In case something is in your way while you're walking, we want to make sure that you can walk on different surfaces. So we're looking at you being able to walk outside, on carpet, on tiles. Anything that comes in your way, you need to be able to overcome and be able to walk around it. We're starting to do things like sensory integration. We want to make sure that you can walk around corners. We want to make sure that you don't have to look at everything. So you shouldn't be walking and looking exactly where you're going. Something comes to the side, you could be able to look at that, talk to them, and still be able to walk. So we're integrating all those movements. We want to make sure that you can do things like lunges, right? And still maintain your level of stability. I want to take a moment to talk about stroke fatigue. It is a very large factor that I don't think people really take into consideration. If you're thinking about it, and we talked about the windshield before, those pathways are all broken, so we now need to retrain them or relearn them. So a very simple activity, or something that we consider something simple that they would have done every day, now requires a lot more energy or fuel to do. So before, you took up a cup, you just reached for the cup, take it up, and had a drink. Now, you'll have to remind your hand that you have to reach for the cup, slowly grasp the cup, hold the cup in your hand, lift it to your head, take a sip, bring it back down, put it back to the table. And you're going to have to do this every single time you want to take a drink. So that activity that was just take a drink has now become 5 or 6 different activities. And this leads to a lot of fatigue. And we will often hear our stroke patients saying to us, you know, simple activities tire me out and I need to take a rest afterwards, right? I'm hearing people saying, yes, that's so true, right? So you need to take that in mind and bear that up to the fact that you need to be able to give yourself some grace and accept the fact that these things are going to take a little longer. As you get, and you're also weaker on that side. So the cup that was weighed nothing to you then now feels like a 100-pound weight that you're lifting every single time. So we want to be able to slow it down. We want to be able to give ourselves grace and understand that this is part of the fatigue. Another thing with the fatigue is that you're now on different medications, right? And sometimes medications react differently with how you're doing, and you want to make sure that you talk to your doctor about this. Yeah, thanks, Tiffany. Yeah. Physiotherapists do work with a team, right? We're all in this together. We are not individuals. We will work alongside the doctors, the nurses, all the other allied health professionals, the occupational therapists, the speech therapists. We want to make sure that you are getting the best care. Speak with your physiotherapist. Talk with them. We have a lot of resources available, and unless you tell us, we are unable to help you, all right? We also are here to support the families, because your families are the ones who are with you throughout the entire time, right? I just want to take a moment here to talk to the caregivers. You're the ones who are with the stroke patient all throughout this recovery. You're the ones who have to continually encourage them and yourselves. So please remember that this is a hard journey for you and a hard journey for them. Remember to be kind and encourage them and speak with them. Sometimes things that we're doing that we think, well, why can't they get this done? Why can't they get this done? It's good to have a discussion with them so that they know, and then y'all can come up with a plan, right? The other thing with remember that shoulder that we were talking about? Very often when those shoulders become subluxed, that is one of our limiting factors to rehabilitation. If that shoulder is so painful you can't roll on it, so painful you can't do anything with it, we really want to remind you that as soon as you start feeling pain or discomfort in that shoulder, get in contact, talk to your therapist, talk to your doctor so we can start doing things about that. The other two things is that remember, as a caregiver, you cannot give from an empty cup. So you have to take care of yourself so you can help them, right? Asking for help is a sign of strength. Right? Thank you very much. Are there any questions?
Dr. Walker-Pusey. I don't think it's a case of not having any questions. I think that we have done so well of informing our patients about physiotherapy and what needs to be done and what should not be done, is that you already know. But maybe there's just still one more person. Okay. Well, thank you, Dr. Walker-Pusey. So we'll take a quick opportunity now to give away a prize, give a gift. Okay, is there anyone here who does not own a blood pressure machine? Don't feel ashamed. Okay. Okay, now you've had that. Any of those whose hands are up, have you had a stroke? Okay, so Dr. Boyce is going to help me here because we have 3 hands up. Okay? So the question is, 4 hands? So physios, look out now. This is a speed round. Speed round. Ready, set, go. Dr. Curtin, forgive me for this question, okay? What would you say is the ideal blood pressure? Ready, set, go. Anyone? Dr. Curtin, what do you think? We will take it. So anybody whose hand went up first? Who? Hers? Okay. Dr. Morris? I want to ask our wonderful Dr. Morris to come and present this prize to this wonderful lady. Well done. Is your sister? Your sister is holding you quite well, correct side. Just well taught, not grabbing on that shoulder that Dr. Pusey talked about, making sure that she is well supported all the way up. Thank you very much. So flowing right along, we've done physiotherapy, we've eaten, we've gone home now. So we want to speak with Miss Buga, there you go, right? She is our occupational therapist. She's a registered occupational therapist practicing here in Barbados. She is an honors graduate from the London School of Occupational Therapy, Brunel University, UK, and that would have been in 2014. For the past 9 years, she's been functioning as the Managing Director and Occupational Therapist for Quality of Life Therapy Services, Inc. Currently, she serves as the sole occupational therapist at the stroke unit of the Queen Elizabeth Hospital. She is a field educator affiliated with McGill University, Canada. And y'all bringing all these words to me. Quinnipiac? Jeez, I was right. University in the USA. She specializes in adult physical dysfunction with certification in the management of stroke, brain injuries, upper limb injuries, and driving rehabilitation. I want to welcome you to the stage. Thanks.
Thank you, Dr. Weeks, for that lovely introduction. It is both an honor and a privilege to address you all today, and I look forward to sharing my insights on the crucial role of occupational therapy, particularly within the context on C10 at the Queen Elizabeth Hospital. I apologize for my voice. I started to lose it yesterday and was fearful that I wouldn't be able to do this. However, our gathering here underscores our shared commitment to improving patient outcomes and advancing our practices. Thank you for your attention over the next 8 slides, and feel free to ask as many questions as you have at the end of this session. The Barbados Occupational Therapy Association also has a table on display with Shireen Muller and Nadia Johnson as local OTs working with us. So in today's session, we are going to look at the multidisciplinary team approach to stroke rehab as it is on the stroke unit here. We're going to learn more about what occupational therapy is, when our services are indicated, how we can help, and why our services are important. Before we move on, I'm just gonna ask everybody in the room, how many of you have had occupational therapy before? One physical therapist hand at the front. 1, 2, 3, 4. I can actually count the hands of people in this room that have received our services. And I will say, 8 years post my commencement on this ward, that is encouraging. Because when I started, nobody knew what we did. And so that's a win in my books. Thank you. So we operate as part of the rehabilitation team. Many of the members that spoke prior to me are members of that team. We also have social workers. We also have in some places, not in Barbados, we have psychologists. There are sometimes the need to have psychiatrists involved. And obviously the doctors are very instrumental in coordinating which services are referred for. Because as you can appreciate, a stroke is a very complex, life-altering event that requires meticulous work from every specialist from the beginning of your experience at QEH, when you enter A&E, to the day that you leave and go back home. Our jobs as occupational therapists on the stroke unit starts from the moment that you are admitted to that ward. Historically, patients presenting to the accident and emergency would be focused more so on the physical elements, the loss of function, the loss of balance, etc. Over the course of our time on the stroke unit, since its inception in 2014 by Professor Corbin and Dr. Mosley, Sister King, and the team of physical therapists and OTs and speech therapists that work so hard on this ward. Before that, there was no coordination of care. People would have a stroke, and the medical team would do their best with the resources that they had. At that time, there was one occupational therapist there, the team of physical therapists, and that was the extent. Now we are more aware of the overarching and wider ramifications of a stroke. And what we've learned for the entirety of the morning is that no two strokes are the same. And so we have patients who present to us who live by themselves and lose the ability to do everything. Speak, stand, swallow, use the toilet. And so we have to work together to figure out how are we going to get this person back home safely, reassuming their identity and their roles post-stroke. So, occupational therapy is a client-centered profession concerned with promoting health and well-being through occupation. Now, we understand as human beings, we are physical, mental, and spiritual beings. And therefore, our work as occupational therapists look at all the domains of life as it pertains to the functional aspects. And in this image, I demonstrate that with self-care, what you do for yourself, putting on clothes, brushing your teeth, putting on shoes, doing your hair, all of those activities will be considered self-care. After that, we look at your work, and we understand that in this context, work is not just your paid job. Some of us are parents, we have homework to do, that is work. Some of us have siblings that we have to support in the household, that is work. Some of us have pets, some of us have a garden that contributes to the well-being of your family, that is considered work. And as an occupational therapist, it's important for us to form your occupational profile that dictates not only the activities that you do, but that the activities that you can no longer do as a result of a stroke, and get you back to doing that by compensation, using assistive devices, which we will get to later in the presentation, or by retraining the function to get you to do that again without assistance. So, occupational therapy is indicated if there is a decline in cognitive function, and cognition is assessed by the occupational therapist and the speech therapist. However, we look at different elements of cognition, and one of our major considerations as not just OTs, but as rehabilitation therapists, is to understand if the patient understands what is happening. Their orientation to the current situation is paramount to the success of our interventions. And so at the beginning, patients are assessed for their level of cognition, and we also specifically look at their current function, so what can the patient do for themselves with this stroke, and we intervene specifically with upper extremities dysfunction. Dr. Walcott-Pusey mentioned the presence of something called a subluxation, and we work very closely together to minimize the ramifications of this very debilitating complication. And so then we look finally at how all of these things impact on your ability to participate in your life. Dr. Walcott-Pusey also had a lovely image of bed transfers and such, and we also assist in that regard to look at specifically the patient's environments, the environments that they're going back home to before the discharge, to ensure that the environment is safe for such, and if it is not, that we make the recommendations and that we point them in the direction of some of our colleagues like Carib Rehab and Warren's Physical Therapy, who provide the equipment to assist these people with maintaining function with these ADLs. So a large part of our profession is supported by the use of evidence-based practice. And evidence is important not only to inform what we do, but also to assist us with promoting our value. As I stated at the beginning of this speech, the fact that so few of you were aware was a success for us. And we have so far to go as a profession, but I am so encouraged
by what I am seeing here today and by what I'm aware of that is happening beyond these walls. And so over the last few years, a lot of evidence has been gathered to support our interventions. And so classically, we would see, this is quite small, and I will ask if this can be shared with you because this is very important. But you can see that there's moderate efficacy in problem solving. So just looking at what the problems are, and there's stronger efficacy at combining problem solving with the stroke techniques and CBT techniques to assist you, not just to identify this is a problem, but to use it as an advantage to build on, to improve your function going forward. I am quite visually impaired, so I have to use my phone. I'm sorry. Also, there is moderate efficacy that supports the transfers, the use of transfers, ADLs, communication, prevention of pressure sores, etc. And there's stronger efficacy that says family-centered empowerment and programs with skills training, identifying the problems on the spot, and then educating specifically about that has been found to have greater outcomes. So, you can go forward there. Right, so currently, I am the only occupational therapist on the stroke unit, and I dedicate 12 hours a week to this work. In my role there, as I stated before, I do cognitive assessment and intervention, functional assessment and intervention, patients who are referred for specific types of strokes to prevent complications in the limbs. We assist with that. We also do home safety assessments, and this is something that I would like to spend a minute on. I know my time is short. However, if you can go forward 2 slides, please. Right, so as of January 2024, there were 410 home safety assessments completed. At the pre-discharge home visit for someone after a stroke in the years pre-COVID took our department on average about 4 hours to complete. With the introduction of the use of telemedicine and further advancements in medicine and rehab, we have now reduced that time to 1 hour, which means we can see more people in the same amount of time. And so I am very keen to continue my work in this department because I see the value directly to the patients. And one of the major markers of the success of this is that there has been a direct relation to hospital readmissions. And so in my presentation, I have references that you can review and see this work. Dr. Mosley and I were just recently accepted to do a speech at the American Congress of Rehab Medicine to discuss the challenges of working on the rehab unit within the context that we work. And so in that context, we wish to share more about the hard work that has been happening there and about the opportunities that we have for further development. So, branching off from the home safety assessments, one of the major areas that we have found to be an area of most complication is the bathroom. And so this image illustrates some of what we do in terms of raising the heights of the toilet to assist the physical therapist with the transferring and in installing safety bars to reduce your fall risk, because as we are aware, falls is one of the major complications of stroke. And then we're going to look at, in this image, a basic living room setup that we most times take for granted because we do this without any issue, pre-stroke, post-stroke, if you have loss of balance, weakness, proprioceptive challenges, sensory processing challenges. Most times your environment has to be adjusted to accommodate you and not the other way around. And so we must be aware of tripping hazards, so removing carpets and rugs where there are impeding walkways. We also have to look at the heights of the chairs. We look at installation of railings along stairways if those are present in our homes. This is just a general example of what is possible. This is tailored based on individuals' environment. And the introduction of the use of technology has allowed us to actually have a greater insight into people's homes without actually going there. And that in itself is beyond valuable, not just for the discharge planning, but for the sensitization of the entire team about what this person's life looks like. So, occupational therapy services in a nutshell help people to adapt to their living environment, restore maximum possible function, participate more fully in day-to-day activities, enhance recovery and outcomes, improve quality of life, and reduction of hospital readmissions. This is an example of the pamphlet that is given to the patients who are referred for home safety evaluations in occupational therapy to assist the families and the carers with the transition from hospital to home. And in this pamphlet was developed by my students from McGill University about 3 years ago. And what we've found is that people having the ability to reference these things negates the need for them to contact us as often as they usually would, because this is a very scary thing that has happened, a very life-altering thing. And at the beginning, people seek comfort in asking questions. And we found that this pamphlet has really helped us to get the message across about what is possible from our perspective. And so, back. And so this is the second page of that pamphlet, and it speaks to specific exercises. And these exercises were created in conjunction with the physical therapist on the stroke team to assist, make sure that there's carryover and continuity in the interventions that we do. And we also look at community reintegration, which is also done with social workers, and as I mentioned many times, home safety. And so I hope that most of you are seeing the rainbow and some light bulbs are coming on, because I know that some of you have no idea about what occupational therapy is, and I hope that by my speech just now, you got a little bit more insight into the value that we add to the team. Thank you for your attention.
Thank you very much. Because we're limited with time, I will let the other presenters present, and then I'll let all of them come collectively to answer your questions. Is that okay? Okay. So some persons received nice little packages when they came in. Our diabetics, we have Lucerna in your bags, just in case your blood sugar is not where it's supposed to be. Could you just go ahead? You can go ahead and drink if you need it. So we don't want to be using any of Dr. Curtin's services here today. Okay, next we did food, we did occupational therapy, we did exercise. Now we're going to bring the speech therapists to the platform. I'm going to welcome now Ms. Cheryl Mapp. Cheryl received her bachelor's degree from the University of North Carolina, Greensboro, before going on to Penn State University to complete her master's degree in speech pathology and audiology. She completed her clinical fellowship years, gaining her certificate of clinical competence with the American Speech Language Hearing Association. Ms. Mapp is currently employed with the Ministry of Health and Wellness and provides speech, language, swallowing evaluations, along with therapy at the ACG Development Center, 2 polyclinics, and the Queen Elizabeth Hospital. She's quite busy. I want to welcome Ms. Mapp to the stage.
Good morning. I would like to thank BPTA for inviting me to present at this conference. I feel very pressured because I have a lot to say in 10 minutes. So I'm just going to get straight to it. So as a speech language pathologist, we deal primarily with communication and the communication issues that patients tend to have following the stroke. And in terms of the communication issues, we're dealing with problems with comprehension, speech, language, and a lot of people don't know that we as speech language pathologists, we also do all the swallowing therapy at the Queen Elizabeth Hospital. And as Dr. Curtin and everybody else has said, the type of issues that you're going to encounter following a stroke depends on the area of the brain that was affected, the size of the lesion, etc. So we're going to start with some of the speech issues that you will have following the stroke. And one of the main ones that everyone identifies is dysarthria. Dysarthria is, deals with the muscles and weakness of the muscles and so on following the stroke. And most of us identify it as slurred speech. A lot of people following stroke, you find that their speech is not as clear or crisp as it was before. And that is because of dysarthria. And some of the symptoms that you will see will be either they're speaking too fast or they're speaking too slow, they are talking very soft, or they might be talking loud. And for some people, you will see hoarseness and breathiness and so on. What we can do for dysarthria, you as the public, you need to encourage people with a stroke mainly to talk slower. Talking slower is going to increase intelligibility because when we talk slower, we exaggerate the way that we talk. So it's a lot easier for people to understand what we're saying when we talk slower. For people who have a very soft voice, you want to encourage them to talk a little bit louder. Of course, if they're shouting, might have to tell them no need to shout. You also, as the patient talks, you want to encourage them to exaggerate the way that they're moving their lips, their tongue. So you're exaggerating the way that you pronounce your consonants in particular. And you will, as I think Melanie had said, when people have had a stroke, no, it was Melissa, sorry, they get very tired very quickly. And it's the same thing with speech. So you will find that some people get tired talking. They use more energy to process what you're saying, and they get tired thinking of how they're talking and making sure that you understand what they are saying. And as a result, when they are tired, their speech sometimes gets a lot worse. Okay? Next slide. Thank you. Another speech issue that we also see at Queen Elizabeth Hospital is apraxia. And this is a motor speech disorder where the connections from the brain to the tongue and the lips and so on are not as they were before the stroke. So the person tends to know exactly what they want to say, but they cannot get the tongue and the lips and all the coordination necessary to get the words out as they were before. I think I've said most of that. They have difficulty imitating words, imitating sounds. Sometimes they go to say one word, the wrong word comes out, okay? But even though we do see speech problems, a lot of what we see are the language issues. And a lot of people who've had strokes end up with aphasia. And aphasia can have comprehension problems as well as the language issues. So they can also have issues with writing as well as reading. So in terms of the comprehension, you might find they're not following instructions as they were before. You ask them a question and they're not giving the correct answer. You ask them, where's the cup? They're going to tell you, I'm going to tongue. You find that they might require a little bit more time to process what you're saying. So you might ask them a question, and there is complete silence to the point where it becomes a little uncomfortable. And it's not that they have not heard what you're saying. They are just requiring a little bit more time to process what you're saying. They also tend to have problems in conversations where there are a lot of people who are talking at the same time. And that is because it takes more energy to pay attention to multiple people than it does to just one person. So you can have the issues with the understanding, and you can also have problems with the expressive language. And one of the main things that you will tend to see is either the speech is fluent or it is non-fluent. So non-fluent speech is where the person really has an issue getting out even a single word. So they know exactly, they may know what they want to say, but they can't get the word across. If they have fluent speech, they can talk in a complete sentence if they have good comprehension. If they do not have good comprehension, they might be carrying on a conversation and you have no idea what they're saying. Okay? You might also see people with aphasia who they go to say pen and pencil comes out. Or they go to say, you ask them what is something and you hold it up and they make up a completely new word. All of that are signs of aphasia. They also substitute words. So you might be looking after someone who says, I want a piece of bread, and you know they don't eat bread. But it's the word that came out at the time. It is not that they want bread, they might want something else, but people with aphasia tend to substitute words. And also you will see people who have difficulty getting their thoughts across easily. So a person who talked well before now can barely get out a single word. Okay? Obviously, the deficits that you will see will depend on exactly where in the brain was affected. And you will also see that there are going to be people who can talk very fluently. You're going to have people who can barely get out a single word. You're going to see patients who have dysarthria as well as people with the aphasia as well. Okay? So what are you going to do in terms of communicating with an aphasic person? The most important thing, and I'm not doing it right now, slow your speech down. You need to make sure that you give that person time to process what you are saying. You also have to give the person time to respond. So if you ask them a question, don't rush them to get an answer out. Wait a few minutes. You want to watch their language and their gestures, and the reason being that sometimes the speech is not coming as they would like, so they start to use nonverbal communication. Some of them will point, they use a lot of gestures. You also want to encourage them to write or to draw or use any other means of communication. Obviously, not everybody can write after stroke because if they were right-handed, they now cannot access that right hand. And if they have reading deficits, they're not going to be able to write. So you might be better off using, the person might be better off using some gestures. You also have to allow for mistakes. We all, when we're talking, we stumble on our words. We don't have perfect speech. So following a stroke, obviously, this person's speech is not going to be as good as it was before. And one of the main things we all tend to do, finish the person's sentences. And we want to try to limit that as much as possible. I'm going to be very quick because I was just told I have 2 minutes. Dysphagia is problems swallowing. And it is not just going from the mouth to the tummy. It is chewing the food, getting it from the front of the mouth to the back of the mouth, and getting it down your throat as safely as possible. Following a stroke, obviously, there is weakness in the face, there is tongue weakness, etc. You will find patients will be drooling. They can no longer chew the chicken and the mutton and everything else that they could before. So a lot of patients following a stroke have at some point problems with swallowing. And you can skip this. Go on to the next slide. Problems swallowing can lead to a multitude of problems. First, dehydration, poor nutrition. If you can't chew the food, or if you find you're coughing a lot as you're eating, you tend to not want to eat, or you avoid certain foods. So that is usually one sign that we always look for following a stroke. One of the major complications following a stroke is aspiration pneumonia, and we want to avoid this at any cost. Aspiration pneumonia is where any foreign substance enters the lungs, and then you develop a pneumonia. And for this dysphasic patients, that will be food or drink. You will find that some people who have problems swallowing do not want to eat in front of people. They are aware that food might fall out of their mouth. They don't want to go out to eat because they need pureed food, and the restaurant is not going to have pureed food. So all of these are things you have to kind of bear in mind when you are dealing with patients who are having problems swallowing. What can you do in terms of people who you might be working with or family members? Always make sure the person is upright. You do not ever want to feed a patient lying down. In a lot of cases, it might not be possible to get that person upright. But the most important thing is to make sure that you do not have this kind of head position. You want a neutral position as much as possible. You want to make sure that they are having the correct texture or consistency of food or liquid. With people who've had strokes, sometimes we have to adjust the type of food that they're eating. If they're having problems chewing, we might have to puree the food. If they're having problems with liquids, we have to thicken the liquids. So most people who've come through QEH will have a swallow assessment to determine what texture food they should be eating and what consistency of liquids they should have. You want to also encourage small bites and small sips. You don't want to be rushing the person to eat, because as you eat faster, things happen and you might end up choking. You also want, if you're feeding the person, you want to make sure that the person actually swallowed before you put more food into their mouth. You want to discourage talking and eating at the same time. Remember that they have had a stroke, the coordination of the muscles and everything are not as strong as they used to be. The same muscles that are used for talking are used for swallowing. So rather than doing two things at one time, let's focus on doing one thing properly. You also, at the end of the meal, want to check to make sure that there is no food left in their mouth. Following a stroke, you have decreased sensation, and food sometimes gets left in the mouth, and the patient is not aware that they have food in their mouth. Best practice, always brush your teeth after a meal, okay? And then make sure that the person remains upright following the meal, because some people do end up having a lot of issues with reflux. And I think that's it. Sorry for rushing.
Thank you, Cheryl. Thank you, Ms. Mapp. Okay, we can take a minute now to answer any questions. We're doing 1 minute. So I can ask Melanie and Cheryl just to stay here. Anyone has a question, please come to the center if they have any questions to ask. Everything seems clear, clear, clear? Crystal clear? Okay.
First is, I'm very enthused about the occupational therapy. How do I get into that? The reason I ask is because I'm a nurse also, and I had a patient who had a stroke. I worked with him 4 years. He had it for 12 years, but for the latter part, I had the end stage. He died on Saturday because of complications. And it was always my interest in rehabilitation, and that thing is, I'm always passionate about rehabilitation and preventative. So how
to
do I get
answer
into
your
that?
question quickly, because we're on a time budget, the law of Barbados states that an occupational therapist can only engage with a patient once a written referral is done from a medical practitioner. So my advice would be to talk to the doctor that's involved in the case. I have the esteemed privilege of working with doctors who understand the value and refer readily, let me not kiss the microphone, sorry, who refer readily to occupational therapy. But the gist of everything that we're saying here today is to be open to the idea that there are other forms of management that exist that also add value to patients' recoveries and their outcomes. Thanks for the question.
One question for the other presenter. is in terms of, I am actually living with my cousin. And what you said exactly is what I'm living with. His speech is very slurred. He wants to say what he wants to say, and it's very hard for him to come out, you know? His right side is weaker than the left, and he drags when he walks. He goes to physiotherapy, but what can I do being there in the home to take care, to further improve?
Oh, that's $1 million question, which is going to take more than 2 minutes to answer. I could talk to you after.
Okay, thank you.
Okay, thanks.
We have so much things to share, so much knowledge. I know you're all overflowing now with all this information, but we still have 4 more things to go. So I know we can try to work as fast. Yeah, so we have 2 more things, and some patients want to share their experience with you. So we're going to move quickly and swiftly. We're going to ask Nurse Knight. She's a registered nurse, 22 years of experience, holds a master's degree in diabetes. She's a nursing officer at the Queen Elizabeth Hospital responsible for diabetes management. And in 2022, she took over the role as the manager of the Transition Community Care Program. And we thought it was necessary for her just to come and speak so you at least know what is out there. So Ms. Knight, please come.
Good afternoon. It's a pleasure to be here. Well, what can I tell you about Transitional Community Care Program? This program came into existence in the height of COVID in 2020, October 2020, and we were tasked at that time to find ways to prevent persons that were frequent flyers to the hospital being admitted frequently to the wards. And you know how difficult it is to stop persons to prevent it to act in an emergency. Initially, we focused on persons with diabetes and heart failure, but now I can safely say we now incorporate a number of other medical conditions into our care. So let me just tell you a bit of what we do. So essentially, you get referred by a doctor once you're in hospital. And if you think you could benefit from our care, essentially when you go home in terms of monitoring of your blood pressure, your blood sugars, we do a holistic nutritional approach as well. So if you go into your homes, you look at your nutrition as well. We also look at social worker intervention. So we have attachments to the National Assistance Board, Meals on Wheels, and I find the majority of our persons on the program have issues with nutrition. They do not want to eat. And with that said, when we incorporate the Meals on Wheels program, we find that persons are able to at least get meals, because that is missing, particularly when you have persons who are known to have diabetes and poorly controlled blood sugars. In terms of monitoring, we get persons to come in, we monitor their vitals, we get the public health nurse involved in the care, we incorporate wound care management as well. So we do everything we can to assist persons from being readmitted to the hospital. And the key word, being readmitted to the hospital. And we also make linkages within the community as well. So we want the persons to get well so they can be discharged from the outpatient setting back into primary care. So it's a way to bridge what we do at the hospital and then make the person well enough to be discharged from the hospital back into primary care. So it's a pretty straightforward program. As I said, you can be referred to the program through any doctor at the hospital once you meet the criteria, and once we go in, we do medication reconciliation, because most of the persons will have issues with medication. They don't want to take it. I don't know for what reason they don't want to take the medication, but I understand with persons with multiple comorbidities like diabetes, hypertension, you have to take a lot of medication and it becomes difficult. So we try to get persons aware how we can best help you. As I said, we do a nutritional support. We also make linkages with the Jesus Christ of Latter-day Saints. So we also give persons food hampers that they can actually prepare meals, because we also look at families as well, getting the entire household well enough to prevent the person from being readmitted to hospital. So it's a new program, as I said, but we're willing to assist where we can. And that is us in a nutshell. So the name of the program is Transitional Community Care Program. As the word suggests, we transition you out. So we want you to get well. We want you to do better. We want to ensure that you don't come back into hospital. As I said, it's easy. Dr. Mosley has access to us through our portal. And if you think the persons can benefit from our services, we just do the referral and we do the assessment. And once you go home, within a matter of days, we're in your home assisting you with what it needs that you can to ensure that you don't come back into hospital. Any questions for me? It was a pleasure. Thank you so much.
We're truly trying to cover all of our bases. So bear with us. We're almost there. We're at the end. We're almost at the finishing line. We're going to invite now Ms. Valerie Allen from the Heart and Stroke Foundation because they're an integral part of rehab. And for those who are not aware, she's going to let us know. So Valerie has been a registered nurse for over 20 years. She's also psychiatric trained. She's a program coordinator in the Cardiac Disease Prevention and Rehabilitation Unit, which facilitates cardiac and stroke rehab, and the Preventative program at the Heart and Stroke Foundation. She is responsible for organizing and coordinating the activities within the unit. She's passionate about inspiring others and firmly believes that with intentionality and consistency, you can conquer anything. Let's welcome Valerie.
Good afternoon to everyone. Don't worry, you will have your lunch very soon. So I'm just going to take you on a journey to Heart and Stroke Foundation in our Cardiac Disease Prevention and Rehabilitation Unit as I introduced to you, for those who don't know, our stroke rehab program. And we actually fall under a logo, say there's life after stroke, because of the effects that stroke can have. You know, some persons may think, well, that is it. You know, my life has finished. But we have a lot of testimonies of persons who have done very well within our program at Heart and Stroke Foundation. So I just want to give a short overview of our beginning. And in 2006, the Heart Foundation of Barbados broadens its mission to include addressing strokes alongside other cardiovascular disease as part of its comprehensive approach to heart health in Barbados. And as a result, it was renamed the Heart and Stroke Foundation of Barbados. And during those years, we saw the stroke rehab program evolving. It is still growing, and it has great potential. And I just want to introduce to you our team. Our team includes our medical director. I call her the gatekeeper because she reviews the referrals and she decides if the person can go on into the stroke rehab program. Then, of course, there's the nurses, the occupational therapists, the rehabilitation therapy technicians, speech therapists, and nutrition. There's one person that is missing from this team. Anybody can tell me? Well, as relates to the therapists, the physical therapist, right? Physiotherapist, right? So at present, we don't have a physiotherapist. So that's hint to physiotherapists here in the room, right? But when it comes to referrals, our referrals are from physiotherapists or from GPs. So the GPs can be from the polyclinics, from QEH, or from private GPs. However, when referrals come into the department, as we review the referrals, there may be a need, even though you have been referred by your GP, there may be a need for you to have a physiotherapist assessment before we can admit you in rehab, right? So some persons want to know, how come I can't get into the program? But again, based on what the information we see, you might have to go back and get the physiotherapist assessment because we do not have a physiotherapist on board. However, we still function as the rehab team. As I say, we have one occupational therapist, some RTTs, and most of the persons here are actually volunteers. As you know, we are an NGO, and sometimes as relates to funds and stuff, we have to wait on donors, subsidies. Persons volunteer their services to assist us in our mission.
And only about 20% of those on that list, I could say, is persons that are actually employed by the Heart and Stroke Foundation. So I must say kudos to those who have volunteered their skills, their expertise to assist us on this mission. So again, going back to referrals, just to note that all the referrals that come into the department must have a date of the stroke and the type of stroke that the person was affected with, the effects of the stroke, and also if there was any investigations, those findings, and also medical history for those who actually does the referrals. Next slide. Right, so what does our stroke rehab looks like? So right now we have enrolled about 45, I think, clients, right? And because of our space and our limited human resources, we usually do a lot of group therapy, and we divide the groups into two. Sometimes we have one team or one group working with hands, and then the other group working with their feet. Then sometimes we do educational session. Of course, that is important. We would have heard about the risk factors that are associated with stroke. So our educational sessions are actually focused on modifying these lifestyle behaviors that will increase the likelihood of stroke. Our support group sessions also is very important within the recovery. We find that the support group is a family. And in that support group, they actually then cater to the psychosocial and the spiritual aspect of the person. We know that man is a biopsychosocial being, and we're not only looking at the physical component of that man, but also the psychological and the spiritual and the emotional, because that will also help speed recovery. So in that support group, you'll find they'll bring in persons who will speak on topics on intimacy and having this strong mindset as relates to recovery. We have beach therapy. Sometimes the therapy will actually go to the beach, and they'll bring the therapy at the beach, and that is a lot of fun for our clients. And they also engage in socials, like birthdays, celebrations after each month. And also, I find that even with the group, for persons that may have some trouble socially, the group has come together where they collect funds, and every month they collect a hamper, and that hamper is presented to 2 clients. And then we have challenges. Last year, the stroke rehab program had Walk a Mile Challenge, and they would have walked on the boardwalk. And we find that there were some that were able to walk a mile, there were some that were able to walk half a mile, there were some that were able to walk quarter mile, but everyone was rewarded with a medal. And this year's challenge is a line dance. And right now, they're actually practicing this line dance for World Stroke Day. So I just want to show a video that I've put together that will give you just a little insight on our program. I hope they can play it. And that is it for me.
If I do the work, the results will come. If I do the work, the results will come. If I do the work, the results will come. If I work smarter, the results will come. If I work harder, the results will come. If I stick at it, the results will come. The results will come. If I refuse to quit, the results will come. If I never give up, the results will come. If I am committed to find a way, the results will come. If I learn more and apply that learning, the results will come.
So remember, consistency and determination. And also to note that there's life after stroke. Thank you.
The results will come. Okay, so we're almost there. So we want to see some results that came and are still coming. I want to ask 2 patients to actually come and just give a 2-minute presentation for us. We're going to start ladies first. So Letitia Eversley is going to come up. She would have had a stroke in December of last year. So she wants to just come and share her experience with us. And she said she'll give me 2 minutes. So let's welcome Ms. Eversley to the stage. So you see that gait pattern? You see how she's using her cane? She did something wrong.
Good afternoon, everyone. My name is Letitia Eversley, and I'm 39 years old. I'm hypertensive, and I am a stroke survivor. On December 21st last year, I suffered a stroke while at home. Luckily for me, I was on the telephone with a friend, so when I told her I wasn't feeling well, she said, okay, I come in and I bring your parents. Because of that quick intervention, I was able to seek medical attention, and I was able to get, the thrombolytics and all the different things, the emergency blood treatment that they mentioned that would scatter the blood clot that was on the right side of my brain. So I would have been diagnosed with a right-sided ischemic stroke, which affected, obviously, the left side. It was very, very scary, but because of my family and my friends, I have an extremely big support network, and that is why I'm here today. The doctors, the nurses, unfortunately, I didn't meet Miss King because I was not on that ward, it was full. So I spent my 2 weeks plus on ward C6. The doctors, the nurses, the ancillary staff, everybody was fantastic. Once I saw my children, that was it for me. I was like, giving up is not an option. I have to fight for my children. And that's exactly what I did. When I left QEH, I was in a wheelchair. I started treatment at the Warren's Physiotherapy Clinic with Dr. Bernie and her fantastic team. And it's because of them today as well that I have made all the progress that I have made. Every day I get up and there's a new purpose. I see my children and I'm like, I have to keep going. Giving up is not an option for me. And to all of my fellow stroke patients here, where there is a will, there is a way, and we will get through this. Thank you.
That was truly moving, wasn't that? So Adrian, you now have somebody to follow up with. This is Adrian Harden, and he's going to speak to us. He's going to give us his story.
Good afternoon. Sadness, fear, pain, shame, embarrassment, all those are emotions that we have as stroke patients. But you know what? One emotion for sure that we must always have is love. And I want to encourage all of our stroke patients here today, don't give up, right? On January 9th this year, I suffered a stroke, and I was completely paralyzed on my left side. I couldn't move nothing. And as you see, I can move something. What I want to encourage us, all those emotions that I mentioned, we have, those are our emotions. We have a right to feel those emotions, but I want to encourage us, don't stay there. Don't stay in fear. Don't stay in doubt. Encourage yourself, because at the end of the day, you are your biggest encouragement. And let me say this, I'm a Christian. Faith without works is dead, and I believe that if you say you have the faith, you must put in the work. And every day, you must do something to make yourself better. So keep at it, keep pushing, don't give up, don't give in. As my good friend said, there's a life after stroke. And I said after stroke because I don't want you to say, this is my stroke. Don't own it. It is something that happened to you. but it's not your stroke. So don't ever say this is my stroke. I never said it's my stroke. I don't want it. It happened to me. But you know what? I will live because, as my good friend just said, I have 3 children, and every day I see them, and I say, you know what? I must live for them. Because there's life after a stroke. So don't give up. Keep pushing. Every day, wake up with an excitement, new passion. What can I do today to make my life better? Because at the end of the day, you must want it. What do you want? You must want it. You must want to get better. And that's my desire every day, to get better. To get better, to get better, to get better. In 5 months, I can cook, I can drive, I can bathe myself, I can feed myself, I can do what I can do before. 5 months ago, I can move my fingers. I can move my toes. When I came out of the hospital, I can move my toes. I can lift my foot. I can do nothing, right? I couldn't do nothing. And when I told my son, his name is, well, one of them, his name is Jade. I said, Jade, when I came to the hospital, I said, Jade, I want to drive. And I said, because I live in Jones, I said, Jade, let's go down Oysters and put gas in this car. And we were driving. I said, Jade, are you scared? He said, scared, Daddy? Were you driving? So surround yourself with positive people, okay? People that will encourage you. You don't want the negativity. And every day, reduce the stress, okay? Don't matter who it is, family or friend, anyone who is in your environment that's bringing you stress, tell them, go, all right? No stress, all right? How much more minutes do I have? That's it? Thank you.
What more can we say? If it's a culmination of everything that's been presented, Letitia and Adrian brought it all to one point. I thank both of you. Give them a round of applause. So we need now to wrap up. I'm going to ask Dr. Boyce, Stacey Boyce, the president of the Barbados Physical Therapy Association, come and move the vote of thanks at this time. Yes.
I've been given 2 minutes. What can I say? Mission accomplished. Stroke Symposium 2024, a holistic approach to stroke management and its prevention is completed. Put your hands together for that. As Gail said, my task is to move the vote of thanks. And firstly, I want to say, to God be the glory, great things he has done. So on the behalf of the Barbados Physical Therapy Association, I want to say a heartfelt thank you to every organization, to every business, to every individual who aligned with us to make today a reality. I could end there, but I think I need to single out some businesses and some persons. To our presenters who so graciously and willingly accepted the challenge to share, you all did excellently. To Dr. Kristen Curtin, medical doctor, Mrs. Christine King, nursing officer, Mr. Robert Carter, pharmacist, Dr. Melissa Walcott-Pusey, physiotherapist, Miss Melanie Buga, occupational therapist, Miss Cheryl Mapp, speech therapist, Miss Shade Haynes, dietitian, Mrs. Valerie Aline from the Heart and Stroke Foundation, and Miss Deborah Knight from the QEH Transition Community Program. Thank you very much. To Miss Letitia Eversley and Mr. Adrian Hardin, you are advocates in your own right for the condition of stroke. And we want to say a very heartfelt thank you to both of you for sharing your journey. We want to say thank you to Dr. Gail Weeks for ably guiding us through this morning's proceedings. To our sponsors, we could not have done it without you. We are truly, truly grateful for you partnering with us to make today the success that it was. So we want to give kudos to Warrens. They're in the house. Give them a big round of applause. Warren's Rehab Supplies, their booth is at the back. Please go down there and venture and see what they have to offer. I see lots of lovely things as it relates to strokes. We want to say thank you to Ross University School of Medicine, Answer Merchant Bank, Back Into Motion, Adapted, Carib Rehab Supplies, and the Queen Elizabeth Hospital for all partnering with us today to make Stroke Symposium 2024 a reality. To all those who made contributions, we sincerely appreciate it. Summit Center, Massey Distribution, Wabisco, Barbados Bottling Company, Philip Brewster Fruit and Veg, and the National Conservation Commission. To NUPW for allowing us to use their facility. And to our team on the left. For the sound system, we say thank you to Gerard Prescott and to Drew Bass Productions for making it possible for those who could not be physically present to still feel the love and hear the wonderful information that was shared today. And of course, to every member of the Barbados Physical Therapy Association who assisted, who contributed in helping to make today the success that it was, I want to sincerely, sincerely thank each of you. I know we should not single out persons, but it would be remiss of me not to single out 4 young people, 4 young physios. I want to single them out today because they have seen this journey through from conception to this very day. And I want to give a big shout out to Mr. Dwayne Hood, to Miss Trudy Bulling, Miss Chantal Brathwaite, and Madam Tiffany Greenidge, who's joined the sound team. You are such an inspiration. I don't know where you guys fit in between the Gen Zs and the, what's the after that? But we are thankful for I'm thankful for the 4 of you who really worked with the symposium. And finally, to you, the audience, who made the decision to be here today. We are so thankful that you came out, and we trust that you were enlightened and that you received valuable information and insight. We hope that this symposium will be a part of a continuum of great things to come as it relates to the landscape of health and wellness in Barbados. Dr. Mandeville, she left earlier, but we want to thank her for coming as the representative from the Ministry of Health to share our opening address with us. That brings us to the end of Stroke Symposium 2024, but it is my custom that after every speech, I like to share a quote. So I want to leave you with this. A healthier you leads to a healthier family. A healthier family leads to a healthier community. A healthier community leads to a healthier nation. A healthy nation is one that is most productive, reliable, and efficient. So as we go forward with the information garnered today, I implore each of us to make wise choices. Someone said, and I heard it in the words of both Adrian and Letitia, that we have 3 choices in life: to give up, to give in, or to give it your all. Let's intentionally today decide to make the choice not to give in, but give of our all to our health and wellness. Thank you very much.
With that being said, thanks again for coming. At the back of the auditorium, we have little gift bags for everyone to take. We have booths at the back of the auditorium for everybody to go and visit and see and learn some more. I want everyone to take their time, get home safely, get something to eat, get something to drink. And until next year, when we do this all over again, Thank you very much for coming.
All right.